Are we live, Simon? Good morning. We are live. It is 10 o'clock on Monday the 13th of December 2021. Can I welcome you to the County Council Chamber for this meeting of Staffordshire's Health and Care Overview and Scrutiny Committee. I am your Chair, County Councillor Jeremy Pert. May I remind members of the committee that today's meeting is being recorded, and for those who want to watch it back, then the recording can be found on the County Council's website. The meeting is being beamed live for people to be involved and will cut off 20 seconds after the equipment has stopped. All voting committee members are in the chamber in person, and thank you everyone for making the effort to be here in person today. And also welcome to our virtual guests for their attendance. I'm just going to make one point to central government, that we have the technology to be able to work from home and hold this meeting virtually. We just seem to lack the desire or determination, which I deeply regret. And I would urge them to get on and make a coherent policy around this, given that the world has moved on and we don't seem to have caught up. Can I thank our guests for their input so far? Can I ask that our presenters restrict their opening comments to 10 minutes, please? And I would like to be strict on the 10 minutes because these are massive agendas, and I'm really keen that we have as much time as possible to scrutinise and look at the evidence and gather the evidence in front of us today. Secondly, can we also focus on the tangible outcomes for residents of Staffordshire? Before we do start, however, I'd like to say a couple of things. First of all, today's session is an additional meeting for this committee, and so thank you for making this possible. And it was clear that we all felt strongly about the residents' experience, both in primary care as well as in acute care. But we should not conflate this with the hard work and dedication of the staff in the NHS who have performed brilliantly during the COVID crisis. We are looking at the system and not the staff and the people within the system. So this is not a critique of them, their efforts or their achievements. And I would ask members to bear that in mind, and maybe at the end we can share our appreciation for what each and every member of staff within the NHS has done over the last 2 years. Secondly, with the arrival of the latest variant, the Omicron variant, the pandemic has not gone away, and we need to urge everyone to get jabbed, double jabbed, and treble jabbed, as well as taking the flu jab, just to protect ourselves, our families, and our friends. Finally, this morning, we will need to be structured so that we can look at these areas in sufficient detail. So I plan to take the GP GP action plan update area by area, one area at a time. And then we can look at the totality of what's there at the end of that session. And for the second item on urgent and emergency care, I plan to take that by functional area. We are not here to scrutinise national policy within that area, and certainly within the papers there is a lengthy document which is titled Hospital Discharge and Community Support. We can scrutinise how that policy is delivered in Staffordshire, but it is not my intention for us to scrutinise national policy. There are other places for doing that appropriately, and that is not our role. I anticipate that we probably will not have all the evidence we would like today, and we may need to come to a conclusion with a following further meeting. Anyway, let's start this morning's meeting by welcoming back a fit and well Deb Breeden.
Thank you, Chair. Good morning, all.
And let's move on to today's agenda. First of all, apologies.
Yes, we have apologies from Rosie Claymore, who's been substituted in here today by Councillor Daniel Maycock, and apologies from Councillor Ian Wilkes.
Thank you, Debs. Can I just confirm that we are quorate? I can see plenty of people in the chamber, so we are quorate. Thank you. So item 2, declarations of interest. Anne Edgeler.
Thank you, Chairman, and good morning, everyone. Yes, I'd like to declare an interest. I'm a partner governor of the MPFT for the County Council.
Duly noted. Any other declarations of interest? None that I'm seeing. Let's move on. So, item 3, general practice update. Lynn, I'm going to hand over to you for the next 10 minutes. So, I'd like to try and move into scrutiny by about 10:15, please. I should have said good morning. Apologies.
That's fine. Good morning, everybody. My name's Lynn Miller. I'm the Director of Primary Care and Medicines Optimisation for the 6 Staffordshire CCGs. So I've circulated a pack. What I want to do today is show how we've moved on over these last 3 months and what improvements have been made. I've also included the 7-point action plan in there that I believe is what Jeremy would like to scrutinise programme by programme. What isn't in the pack, though, is developments this weekend around the ramping up of the vaccination programme and what that means for general practice. And what I'll do is I'll run through the slides first of all, and then this weekend's developments and what that means for the next 3 weeks I shall also touch on, if that's okay, Jeremy, because it's very pertinent to the plan, really. So if we can put the slides on the screen, please. I presume our comms team are here. Lovely, thank you. Thanks, Alana. So, in terms of the first slide, what Jeremy really wanted to do was talk numbers. So what this shows is the activity in general practice over the last 4 or 5 months. We've compared 2020 levels to 2019 levels, because obviously last year was a strange year. But what it shows is there's been a significant spike in demand for general practice, peaking in June, but pretty much it's been around 11% for the 5-month period. You can see in October that there was no change between October 21 to October 2019. I've tried to understand this, and I think the main reason would be that October is our biggest month for flu vaccinations, and I think that's what's happened. We've focused on flu vaccinations in October, and we'll see what happens in November. But it may be that we've just seen a spike, and hopefully we're coming out the other side. Just in terms of the next slide again, what I wanted to show was the sort of different health professionals' roles and who sees who. The vast majority of appointments are delivered by general practice, but you can see we've got a huge practice nurse workforce that see patients. We've also got advanced nurse practitioners, and increasingly we're seeing a role for clinical pharmacists as well. So some good news really. So we saw a huge dip during the pandemic in terms of face-to-face appointments. Face-to-face appointments during the pandemic at its height were around 20%, with the majority of capacity delivered remotely. And since then, we've seen a gradual increase in that face-to-face appointments. What this slide shows is a report in the Health Service Journal that shows Staffordshire and Stoke-on-Trent were the most improved system in the whole of the country in terms of the increase in face-to-face appointments. So we had a 6.2% increase in our appointments between August and September. For me, this ties in with the audit checklist that we did in the same period. So we had 112 practices respond to that audit checklist. We saw a corresponding jump that month. So I think it does show that the work we're doing is having an impact. We weren't particularly from a low base either, so we were around national average. We're just above national average in terms of face-to-face appointments now. So about 62% of our appointments are delivered on a face-to-face basis, and actually that's starting to feel like quite a good balance for people. If we move to the next slide, I showed this slide last time in terms of the new workforce that primary care networks are attracting, and month on month we're seeing this figure grow. So when I last came to the OSC, I think we'd appointed 145 whole-time equivalents. That's jumped to 180 full-time equivalents, new roles that over and above the baseline compared to the previous year. So these are things like social prescribers, first contact physios, clinical pharmacists, and they form part of that wider multidisciplinary team. So it's really about a range of workforce that are actually probably best suited to certain conditions, and hopefully this will give a better outcome for patients than just seeing a GP, which historically, I'll say just in inverted commas, but it's a new way of working, and I think we need to promote this and do a lot more communications about the different workforce that people might see in general practice. The next slide describes winter, because Obviously, we see a surge in capacity in winter. It will be over and above what we've been seeing through the year. And we've got very robust plans in place. So there are 4 programmes of work that we're putting in place over winter too. So project 1, the first one, is around respiratory hubs for paediatrics. We're expecting an increase in respiratory over the winter period. Certainly that hasn't happened to the extent that we were expecting, but we are planning for that because we could see a surge at any point. So we've got 3 hubs that we are planning across the whole of the county. The northern hub is in place now. It's seen around 300 patients a week through that hub, and we're seeing good uptake rates. That will follow with a south west and southeast hub as well, and we'll switch that on over the next couple of weeks. The second programme of work is around additional capacity in primary care. So we've commissioned a model from all of our practices, either at a practice or a primary care network level, to provide either 30 minutes per 1,000 patients or 60. And I'm just collating how much activity a week that is, but potentially up to 4,000 additional appointments per week. The other programmes of work around BP monitoring at home and pulse oximetry at home. This is about preventative measures. This is about self-care. We've got hundreds of blood pressure monitors that we've commissioned, and we're getting those out to the community so people can monitor their own blood pressure. And again, that's one way of stopping anybody's blood pressure escalating and needing a hospital appointment. We've also commissioned 111 to provide additional dispositions in primary care. This is about freeing up general capacity. So rather than going back to the GP, 111 will manage that capacity themselves. So again, it's about using as much capacity as we can, but freeing up general practice who have obviously got the additional pressure of the vaccination programme to deal with too. The slide that isn't included in the pack that I just wanted to touch on was around the Together Against Abuse campaign. So increasingly in general practice, we're seeing daily acts of verbal aggression, but we've also seen some quite nasty physical aggression against our practice staff. It's having a huge impact on our frontline staff, particularly most junior members, so our receptionists. And we've launched a campaign which you'll be able to access through the Together We're Better website. And I would urge you to have a look at that. We've got a YouTube video that's quite strong, actually, around the kind of abuse that practices are receiving and the impact on them. We've had a number of physical attacks on patients. There was one at the weekend. You might have seen the CCTV footage on the BBC Breakfast News, where a patient jumped over the reception and started to attack staff physically. We've had patients fighting in reception as well. So the campaign is really about being patient, zero tolerance around abuse. So I'll move on quickly to the 7 work programmes. I wasn't planning on going through these in a lot of detail given the scrutiny that I think that you want to go through, but you can see we've got 7 programmes of work. Here's the slide. They've put it in here. I do apologise. The first one being comms. This has been the most important piece of work for us in terms of communicating with the public, social media campaigns for practices. But the Together Against Abuse campaign is something that we launched last week, and it's really important that we get this out to as many people as possible. You can see some of the comments that practice staff have had to deal with, and it's quite staff have said they're afraid they get abused in the streets, and we just can't tolerate that. So it's a campaign that started in primary care, but it will apply to the whole of the system, and certainly colleagues in secondary care also have to deal with these acts of aggression, and it's something that we cannot tolerate. We've put on a number of resilience training for staff. It's been really high uptake rates on that, about how to deal with difficult people, but we're seeing a whole spectrum of abuse that staff have to deal with. As you can see, lots of communication happening. I won't go into that line by line, but I can pick up any questions that people have afterwards. The Access Improvement Programme, also known as Time for Care. This is about a more tailored approach on a practice-by-practice basis. So we know that the majority of our practices in Staffordshire and Stoke-on-Trent are good or outstanding. I think we're at 96% now. But we do know that there are some practices that have poor access. They were poor before the pandemic, and they're poor now. We know who they are. This is a low number, but this tarnishes the rest of primary care, I think. So we're working with those practices who provide low face-to-face appointments, not a lot of appointments generally, at the wrong time, and who are considered to be, often we say the doors were shut. Well, these are the practices we're working with. The programme's also targeted for more positive practices who want to change and use it, be innovative. So it's open to everybody, but we target those practices that need it most. In terms of record keeping, you can see the audit checklist that we carried out that had that impact in August and September. This is about, again, practices adopting best practice, but tailoring it to their own ways of working. And we continually modify this and work with our practices to make sure we are spreading best practice. We rely on digital solutions now, obviously, with remote working. We've been very quick off the mark during the pandemic, and a lot of that digital way of working we're continuing now. So you can see there's things like cloud telephony that are supporting our telephone access. Our online consults, we were ramping that up, but when I talk a bit about the vaccination programme, I also need to flag that some of these things have been paused, so particularly online consultations, that target's been stretched into the new year so we can focus on vaccinating over the next 2 weeks. Again, we've got a programme of work around quality and variation. As I said, not all practices are at the same standards, and we monitor this very closely because access is a sign of quality in many cases. So there's a number of indicators that we're using to assess quality, but access is the thing that people are talking about, but I think it's a lot more complex than that. Obviously that important, it has 2 slides. Training and development, this is a continual programme of work, so we support care navigation. That means that we need to make sure our receptionists are trained and understand the right way of questioning. We've got training sessions on demand and capacity, so we can ensure that practices tailor their busiest times with the right level of appointments. And that's a continual process of improvement and development really for our practices. In terms of workload, this is hugely important. We need to ensure that practices work in the optimal way. So this programme of work is about, again, best practice, but it's operational. So we're also adopting, making sure that we're getting the most out of our practices, the most out of our primary care workforce, including community pharmacy. So we're developing a community pharmacy referral service. During the pandemic, particularly with the vaccination programme, primary care networks have started to work more closely with their pharmacists, so that's really helpful. We need to maximise the whole of the primary care workforce. To final slide, we obviously need to make sure that what we're doing is working. Here you can see we've got an example of our 360 degree report that we have for every single practice. There are 61 indicators in there. It's not just about opening hours or access. This is about the quality of access, really. So it looks at our long-term condition registers. It looks at referrals to A&E. It looks at antibiotic prescribing. So high antibiotic prescribers is an indicator of perhaps poor practice. And we go through this on a practice-by-practice basis. And after Christmas, we're starting our quality visit programme. We'll be visiting every single practice in Stafford and Stoke-on-Trent, and we'll be going through this 360 degree report with a clinician, with the practice in a very supportive way. So I shall pause there, if that's okay, Jeremy. Oh, the other thing I just wanted to say, and apologies I haven't got a slide, but it's kind of breaking news, really. You will have heard on the news last night with Boris's announcements about the ramping up of the vaccination programme. This will require Staffordshire and Stoke-on-Trent to vaccinate 359,000 people for their boosters by the 31st of December. So we've got 3 weeks to pretty much boost the remaining of our population, all over 18s, but also continue with that evergreen offer to make sure people can still access their first and second doses. Clearly, this is going to be a huge challenge. The vast majority, 60–70% of the vaccination programme is delivered in primary care through mostly GPs and PCNs, but also community pharmacists. We've stepped down for this period a number of enhanced services that practices deliver. So you might have heard nationally they've given instruction to stand down the QOF, the Quality and Outcomes Framework, to pause and defer any new over 75 health checks, to stand down the improvement programme for PCNs, which is largely around surveys. There's a lot of administrative burden that we can take away. This weekend, though, the message has been very loud and clear. The vaccination programme after emergency surgery is the most important piece of work for the NHS to be focusing on over the next 3 weeks. So we have to prioritise vaccinations. This may mean that some people's routine care may be deferred into the new year. We will catch up. We will continue with our long-term conditions reviews, and we'll pick this work afterward once we've got through the body of the vaccinations. But very clear message: if we don't vaccinate, if we don't boost the remaining population, we are going to be storing up a problem in January. So what I would ask members is for your support around that message. We need to define what that means for patients. Patients still will be able to get emergency appointments with their GP. We will still be screening patients, and we'll be still prioritising cancer. But it may be that some more routine work may be pushed into the new year. We are meeting with our primary care clinical directors today to have that conversation. It is a small period of time. It is over the Christmas period when it's perhaps quieter, but it is a message that we'll need to ensure that we're all signed up to, so we can actually make sure we can deliver the government task, which is 360,000 people boosted before we go into the new year. So I'll pause there, Jeremy, if that's okay.
Thank you, Lynn. And thank you also for maintaining our timelines. Can I just pick up the last point first? Is there any questions that members may have relating to Omicron and what Lynn's talked about in terms of the vaccination programme? Surprisingly, no one's indicating. So, Charlotte.
Well, I really want to ask about the QOF, because it may well be that you're suspending that for 3 weeks during the sort of national emergency to get the vaccinations done. But I'm more interested in the long-term issues around QOF, because, of course, the BMA have been lobbying for a very long time to take that function out of GP surgeries. And my concern is that if you don't have, we do know that GPs tend to respond to financial incentives, put it that way. And if they don't have to abide by the QOF guidelines, then my concern is that those vulnerable patients who are supposed under the QOF guidelines to have regular assessments and checkups by GPs, that they will go by the wayside. Now, I'm not talking about the next 3 weeks. I'm talking about January onwards, when I'm really concerned that those people will go unmonitored. However, well-intentioned GPs are, we all know that from the statistics that the demand has increased. And my concern is that what safeguards are you putting in place to ensure that GPs don't forget about those patients, because I fear that QOF is going to go out of the window.
Thank you, Charlotte. That's a really good question. So the government have stepped down QOF until the end of March. However, there are elements that will be maintained. So continue with the immunisation, screening cancer is an absolute priority. It's down to a clinical decision, and it's actually a tiered step down. So it's not completely paused. Those patients who are most clinically at risk in that top 20% will continue to receive their reviews, and patients outside of the QOF will still be able to see their GP if they need to. So it's around a clinical decision, really. The majority of the QOF has already been delivered. The payment has been protected, but it is down to, we've agreed this with the local medical committee, that actually we need to give some very clear guidance of what we expect in terms of a clinical priority. In terms of the mitigations that we're putting in place, I think there's a bigger issue here, that this is not about a 3-week pause or a pause to the end of March. This has been 18 months during a pandemic where people have not been getting their routine care. QOF was paused previously, but also people didn't come forward for their long-term condition reviews. What I'm doing at the moment is we're doing a full data review to understand if there has been an impact on QOF outcomes over the last 2-year period. Once we've got that, we're looking to put in a QOF recovery plan in April onwards, where we'll front load the majority of our reviews into the new year. So actually what I'm hoping you'll see, firstly, we need to see if there's been an impact at all. There may well have been, but secondly, by bringing the majority of activity forward into the beginning of April, we'll actually have a minimal impact on patient outcomes. So that's the mitigation that we're putting in place.
My concern is that even in my town of Leek, I can see great variations in the delivery by different GP practices, and my concern is that the worst will become the norm rather than the best. So how are you going to make sure that those GP practices that don't perform as well as others are monitored and ensure that they do not fail their patients?
Yeah, we've only got 2 practices in the whole of Staffordshire who are inadequate or requires improvement at the moment, and one we've got a recovery plan. So the majority of our practices are good or outstanding, and QOF is an indicator that the CQC review. So they'll look at those indicators. There will be variation, there always will be, and that's where the 360-degree review comes in. That's a practice level review. A lot of the QOF indicators are included in that. So you'll often see that practices are good at some things and not so good at others. And it's that very detailed process of reviewing every single practice and where they are that will help with the response. And this is where we can build a support package around them in terms of training and development, peer support, and very, very detailed monitoring and making sure that we see the improvements that we need. But absolutely, there is always variation. But I will say that our practices are largely good or outstanding in this county.
Can I bring in Keith?
Thank you, Chair. My question really is, I know it's very early days now, and I know that you probably haven't got a plan laid down for everything else, but obviously there's going to be a marked increase in the amount of vaccinations that are going to be needed. I was basically asking about walk-in centres, things like this, away from GP surgeries to take the stress again off GP practices and access to services that we're in. I know it's very early days, but when do you think a plan might be able to be worked up and for us to be able to distribute any details of that plan? Thank you.
I've already got a plan, actually, Keith. So we have got a plan. We'll have a list of locations that we can circulate very quickly for you. We've got a blended model. So the majority of vaccinations are provided by primary care networks and practices, but we've also got 44 community pharmacists on board now. We've got our Tunstall vaccination team. We've also at Centre. We've also got a roving team that's largely delivered by MPFT, but we've got all of our stakeholders involved, and the fire service even are hugely helpful to us in terms of helping us with logistics of setting up pop-up clinics, etc. So the plan that we have will be around using all of our capacity and absolutely maximising it over the next 3-week period. So we need 15-hour days at our vaccination centre. We need weekend working. We've got to do an additional 21,000 vaccines a day to be able to deliver the target, 126,000 vaccines a week. So it's a huge challenge, but I think we do need to recognise we are going to have to pull on GPs over this next 2 to 3 week period to be able to deliver that. But we will have other sites that will be setting up. We've already had some offers of support this morning from Richard Harling about supporting additional high street pop-up clinics. So we will take all the help that we're offered, but I'm happy to be able to share the plan with the OSC virtually and make sure that everybody's aware of those centres and where clinics are going to be run. And how people will access them. I've just got a call with my team this morning where we're pulling everything together in terms of the comms, the workforce, the estates. So we'll have that very quickly by lunchtime, I would say.
Keith?
Yeah, well, thank you very much for that. I'm glad to hear that we've got something coming up to try and take the weight off the GPs a little bit, because that's what we're here looking at the moment. I'm sure, and I say Johnny's here in the chamber with us at the moment, but I'm sure there's been some comms worked up and everything else. But if there's anything else that you think members can help out with, or anything else in the community that you might need additional help with, by all means, if you can put that in the plan, let us know, and then we can maybe ask around, because I know there's several areas, particularly in Biddulph, in that area where they can do some additional vaccinations. I'm sure they'll be happy to help out. Thank you.
Keith. I think what we do need is people's support for our practices at the moment. So any messages that councillors can put out to their constituents around perhaps being a little patient with practices at the moment would be very helpful, I think.
Thanks, Lynn. That's certainly meeting some nodding of heads this side. So as soon as you've got the plan, more than happy to see it, and we'll get it circulated as far and wide as we can, and through Christian Marcucci as well. Just a couple of questions from me, if I can, please. First of all, do we have the availability of supply? And secondly, do we have the availability of labour?
Yeah, so in terms of supply, we've got 90,000 vaccines in stock this week. So we need to deliver a capacity of 126,000. So at the moment, we're just doing that review with primary care networks, the community pharmacies, to say what stock do you have in your fridge, what do you need? So the expectation is vaccine availability won't be a problem. So we've got double vaccine delivery coming from tomorrow onwards. So I'm confident that the vaccine's available. Workforce, we've already got a very tired, worn out workforce, if I'm absolutely honest. GPs know this is the right thing to do. And actually, if we don't vaccinate people, we're going to have a lot of poorly people after Christmas, potentially. So it's in their own interest to make sure that we do this piece of work, and everybody's committed that. We've got 100% of our PCNs on board. So the whole of Staffordshire is covered from a primary care network perspective. We've got a very good workforce hub and workforce programme led by MPFT. It's a system hub of workforce, so that will be the first priority for us, to get as many registered vaccinators, volunteers onboarded onto that hub, so we can actually start distributing people out to wherever we need them.
Thanks. Just in terms of figures, I understand there is 6 million people in the UK who aren't immunised. And do we know what the number is in Staffordshire? And do we know how many have had 2 jabs but should have had a third and haven't? I mean, is that the 359? How does that relate to the numbers?
Yeah, I should have got that up and anticipated that question. We've got an absolute understanding of how many people are left to be vaccinated. If you can bear with me then, Jeremy, I'll pull that up. So as of this morning, actually, we've got, we're currently at 75% of our population is vaccinated, boosted rather. So we've got a remaining, I shall have to work it out. We've got probably we've got 359,000 people that need a booster, but we've also got a number of people who haven't had their first and second dose. I'd have to just go and find it, Jeremy, if you can just bear with me, and I'll get it for you.
Do you want to just drop us a note later in the day on those numbers? Once you've done your plan, obviously, because I think the plan is probably more important. And then, if you can just share some of those numbers, we'll share those with the local outbreak control board as well, just so there is a wider visibility. Philip Atkins.
Thank you, Chairman. Trying to get back on track. Obviously, the vaccination is really key at the moment, and encouraging people to get the booster jabs, or at least the first jab, and obviously there's some parts of the county, and I mentioned it on Thursday, Anglesey, where there's only 37% take-up of any vaccination. But I'm just a little bit concerned about access to GPs surgery still, and the training for receptionists doesn't really get to the nub of the problem. People are frustrated if they're going to have a go at the receptionist, and you're training receptionists how to do anger management and all the rest of it. That doesn't get to the bottom of the original problem, is people's frustration that they haven't been able to access a GP. Now, if we're changing the way that people access the GP from face-to-face to digital solutions, and I've used the 111 line and it's quite good. If you're going to do that, there is nothing in these reports about the way forward and how you're going to try and do something about that. And I'm looking for evidence about how people understand this. They will have seen something on the television last night about booster vaccinations. I had to get in touch with Johnny McMahon because I had some relatives went to a walk-in centre at Norton Keynes at Cannock and it was shut. It had been shut for days, and it was still on the NHS website. So there's something about the communication behind all this story that isn't ringing true. It isn't right. And I'm sorry, you know, these things lead to other things, and you can end up in a mess. And health scrutiny's role to look at health, not the NHS. So we're not micromanaging you, but the information that you've got in this paper is not enough to engage with 14 GP practices out of 156 is inadequate. So I just want to know, what is the plan? Then we can have a look at it. This is looking back, and please don't give us too much pressure, because we've got this big job to do over the next 3 weeks. And I've got a nurse I've got a daughter who's a nurse who does vaccinations and been doing it for 6 months. You know, I don't know how many hundred a day she does, so I know what's going on about that. And I'm aware of it, but that doesn't give an excuse for those that still, you can't get into the GP surgery. I go past the one next to me, and there's a queue of 70-plus-year-olds waiting to collect their prescriptions in the pouring rain. That is not right. You've just said that you know where they are. You've had 20 months to do something about it, and nothing's happened.
There was a lot in there, Lynn, so do you want to just pick some of the bones out of that? I don't think you'll fully get to, you'll be recreating the whole of GP practices.
Yeah, and I think there
maybe
is
the
something
answer.
about this. Yeah, I mean, there is something that's perhaps a broader issue around the strategy. So what we've been asked to present is a plan that's got obviously the 7 key areas about what we're doing now, but there is a piece of work around, well, what does the model of care look like for general practice going forward over the next 1, 2, 3, 4, 5 years? So that's a separate conversation, but it's equally as important, I think. Just in terms of the numbers, I think one of the biggest problems for me, you can see that general practice is around 400,000 patients' appointments a month. It's huge, it's eye-watering. I think what is more so, though, is the number of telephone calls, and that's where it's been falling down. So we've got a fixed workforce in primary care, but we've got a huge peak in activity. So biggest peak was in January, in June rather, with around 70,000 additional appointments in that month. But again, the volumes that we talk about mean that we've got a fixed capacity, but practices are doing at least 2 or 3 additional surgeries a week within that capacity. So I would say that practices are doing over and above what they've ever done before in terms of the volumes of work that are going through practices. But I think we've certainly peaked, or there is a spike, if you like, following. You can see very clearly on the 12th of April, when lockdown ended, a huge rush to general practice, and that's where we are at the moment. Same levels of capacity, but increasing demand. You saw in October that it started to come down. I don't know if that's going to be a permanent feature or if that's going to continue, and hopefully it will do. Hopefully those people that didn't come forward for their prescriptions, their meds reviews, have caught up, but we'll see that as time goes on. What still is a huge problem for us is the volume of calls. We did an audit and we were seeing another 100,000 calls a week in our practices. We've bought additional phone lines. We've got new ways of using Teams, additional cloud-based telephony, things like that we've put in place. But again, we've only got so many people in the workforce to answer the phones, and that's our real problem. So people are waiting for a long time on the phone. That's something I do acknowledge. And we're working with practices again about different solutions that we can put in place. In terms of the abuse, though, I do recognise that people are frustrated, but actually that's having a knock-on effect on our receptionist staff. They are walking out in droves. So we've got an added problem now that we've got even less staff than we did 12 to 18 months ago, when people don't want to come and work in a doctor's surgery at the moment because of the levels of abuse, which I will say is daily. But no, I absolutely take your point. We do need to do more. We will be meeting with all 146 of our practices. We do that every single year. We also have a target approach for the bottom 20%. There'll always be a bottom 20%, but we work with them on a very much a one-to-one basis. All of our practices don't need that added support. They're providing a good level of access. It's just a bit strained at the moment.
Can I come back, Chairman?
Yeah.
There was 2 things, but it mentioned that there was a change over the next 1 to 5 years. The question is, when do we get to see that? Because that's a significant change in the way that health services are given to the population. And the other one is that, yes, I take the point about you've engaged in this paper with 14 and 146, and some that won't need engagement. But there is nothing in the report that says these are, you know, I know what GPs are like. You know, there's some that are really good in getting on with the job and don't want the hassle of health scrutiny and all the rest of it coming in because they're doing a good job. And from my experience in farming, if you're in the red tractor and you're doing it, you should have a light touch inspection and not have a full-blown one because you're on top of the job. It's those few, probably about 20, where we can't get into very well and where we need to do things with that. Sometimes, tongue-in-cheek, those that volunteer the most information are the ones you need to have a look at because they've got most to hide. Whereas those that are getting on with the job haven't got time to bother with you, you know. So there's a little bit about where's your plan of action about sorting out these GP surgeries, where the abuse is. That could be one way you look at. Where's the most abuse? Is it to every single practice, or is it just to 10 or a dozen that are losing them because the GP won't see them, won't see the patient, sorry.
What I can say, the abuse is pretty widespread across all of our practices. It's happening everywhere at the moment, which is really disappointing. In terms of those bottom 20%, we do work with those practices. Unfortunately, some practices won't change or haven't changed. Very, very few number, though. So I'm talking a handful that we know. We've worked with them for a number of times. The intensive support team's gone in. The CQC have been working with them. They're not going to change. And in some cases, we have to be very decisive. And we have removed contracts before. And we've done that very recently. It is very difficult to remove a practice contract, though. These contracts are given in perpetuity to the partners, which means forever. And removing a contract is extremely difficult. I've only done it 2 or 3 times. Usually we would work with the CQC and they would manage it on quality and safety grounds, but poor access isn't a reason to remove a contract. So we have to really engage with practices to help them to change, but very, very few number of times where that's just not possible and we're not seeing the change that we need, but that is a rarity. I will go back to the majority of practices are doing their best at the moment, though.
Chairman, sometimes an example of one doesn't get the attention of the others.
Yeah.
Thank you, Philip. I'd like to try and move towards scrutinising the individual action areas, but I'm just mindful that Anne Edgeler and Phil Hewitt wanted to come in.
I want to refer, thank you, Chairman. I wanted to refer to the presentation that Lynn gave, actually.
So can we pick that up as we go then?
Okay.
Phil?
Thank you, Chair, and I'll be extremely brief. I'm sure Councillor Atkins won't mind be taken into a task on an individual point. He's now mentioned Norton Keynes practice on 2 separate occasions in a public meeting.
Chair, it was the dental practice.
Yes, I know what practice it is, and he's now mentioned Norton Keynes dental practice. Does that clarify the situation, Councillor Atkins? Thank you. And criticising it in 2 public meetings. From my experience and my residents' experience, they serve a lot of my residents, it has been a superb operation. Well managed, well constructed. I don't know the situation where the individual relation went and there wasn't open, but we haven't found that locally. In fact, reputationally, it's been absolutely excellent, absolutely superb. So I think it's right just to say that that practice or that dental practice has been mentioned twice publicly, and I think it's right to put a correction in of somebody who lives 2 miles from it. I have had no emails, no problems, no complaints. In fact, reputationally, it's very good, and I'm sure Councillor Atkins won't mind me correcting that, but I think he needed to say, as it been mentioned in 2 public meetings now. Thank you, Chair.
Right, I'm going to, thank you, Phil. I'm going to call a halt to that bit and we're going to move on to scrutinising of the action plan. I think you make a good point in as much as when we're in a crisis, we need to pull together and work collaboratively to find a way through. And I'm sure that that's the aim of everyone. So I'm going to start on page 10 now. There's an action area that is entitled communications. There's a lot of detail within that. And I'm looking for any comments, questions, thoughts. Janice, good morning.
Good morning, thank you. Lynn, I was pleased to see the extra slide that you showed earlier on about, say, staff abuse. that I think that definitely needed to be explored further, to establish any trends in that particular part. I agree with what some of the other colleagues have mentioned so far, that I can appreciate that some of that is born out of frustration with booking appointments, and it does, Chair, if you don't mind me linking with another aspect on page 13, which is looking at how we can have an online facility. Previously, we've had conversations about the NHS app and how people can book appointments. How we can try and make sure that that's a consistent offering, I think, is going to be helpful in the future, but also linking in with some of the other aspects is how we can make sure that those patients are then directed to the most appropriate person who's going to be able to help them. And it isn't just going to be a case of booking solely with the GP. So I can see it's how that synergy's there. I'm also mindful, whilst we're having this conversation, about the fact that we are needing to pull together. And I think that access in those systems is a wider picture. And certainly the plan that we should be seeing later on today, I think hopefully will also include information about how best to access the facilities, whether it's going in for the booster, which I can put my left hand up and say I had mine yesterday, thank you very much. Yeah, I think it is about access and how that can hopefully alleviate some of the staff abuse that's been endured and certainly not accepted. Thank you.
Mm-hmm. Thank you. I think digital is a huge priority for us as part of our strategy, actually, in terms of how we can free up capacity by using digital solutions and make it more convenient for people. So I think having that blend of remote and face-to-face working is an example of how we use digital. There is a target to increase our online booking, but that's been paused. Each practice is different in terms of its operating model and staffing model. So I absolutely agree we need some consistency, but we also need to recognise there will be difference. But no, thank you. That's helpful comments.
Do you want to come back? Okay. Does anyone else want to pick up any points in terms of the communication area 1? Paul.
Thank you very much, and good morning. I just want to pick up on the communications point that's been mentioned. And do we still have that position where GPs are still using different bits of software that doesn't instantly communicate with other areas? I'm just thinking that, this was mentioned many, many years ago, and I just want that reassurance that you continued to standardise the communications systems that importantly link up to hospital referrals, because we are still aware that it's not compatible, and in some areas people are finding themselves at consultations and the records haven't followed them for whatever reason. So I'd just like that reassurance that I realise that isn't an instant overnight success, but the reassurance that you're working towards that standardised model will be very helpful. Thank you.
Thank you. In terms of the clinical systems that the practices use, the majority of our practices use a system called EMIS. We do have a few System 1 sites. So this is about how patient information is recorded. This isn't part of the discussion today, but as a system, we're developing an integrated care record about joining up different parts of the NHS, because believe it or not, we don't all have one shared system that the hospital can access and general practice can see into the hospital systems, but we've got bits of that. So things like pathology requests, they are shared across the system. We've got data sharing agreements in place that practices can share data with each other. Increasingly, they're providing services at scale, be it extended access or the vaccination programme that requires the GP to access a different practice's patient level detail. So that's in place. But I think, and in terms of the booking systems that practices use, they use what works. And there's a system called AccuBook at the moment that's very effective with booking appointments for the vaccination programme. So I think practices are sharing information between each other. The system is starting to share information between the different pillars, if you like. And for me, it's the integrated care record that will pull all of that together. So I hope that answers your question. We need to be consistent in terms of patient access, but information, organisations being able to access patient information when it's clinically required.
Thank you very much for that. I will maybe come back on that in the future. Thank you.
Okay, thanks.
Before we move on, Lynn, I just want to make one point, which is sometimes, with communication, that's a pushing out of a message. Actually, if Staffordshire's residents saw something different, I think that information would fly out like wildfire a lot quicker than actually trying to get messages to people. And I think that, a standardised offer for Staffordshire's residents which was very clear, whether it was in terms of booking appointments online, I look at certain practices you can and certain practices you can't. And I think we should maybe look towards what could we offer as a standard promise to Staffordshire's residents, and then you wouldn't need to do the proactive communication stuff. Don't tell my friend Tracy Shewan that, but you wouldn't need to do that proactive pushing out of message, because people would talk about what a great customer experience is. Amazon does not spend millions on marketing about its customer experience.
It sounds like you've been talking to Dr. Paddy Hannigan, actually, Jeremy. So for me, that is the primary care strategy. This is an access plan. It's a point in time of things that we're doing to improve access, but the strategy is about universality. It's about a consistent offer for patients from their practice. The intention was to start that work before Christmas, but actually, given where we are, that's not the time. So we will be looking in the new year to engage and develop that primary care strategy, which is a consistent one. You might have heard me talk about the universal offer before. This was the first step towards that. It's 15 service lines that are provided consistently by every practice in Staffordshire. So things like phlebotomy, etc. So we've started the piece of work around consistency, but we've got a lot more to do, and that will be the strategy, the basis for it, really, Jeremy.
I welcome that response, and I'm glad I'm on the page. Let me bring in Anne Nedgler, then Richard, and then we'll come over.
Thank you very much, Chairman, and thank you for your presentation, Lynn. Talking about communications, do all councillors have access to their patient participation group in their area? Because we've got a very good one in our area, actually, and when she's the secretary, and when she puts the minutes out, she puts it on the social media in our local pages, so everybody gets to know what's happening. I just wondered whether, that is common practice.
Yeah, most practices do have a PPG, a patient participation group, and they're very active and a very good way of communicating with patients. It's not a contractual requirement, so I've probably got a handful of practices that don't have a PPG, but the vast majority do. And in a way, it's not worth their while not having one, because it is an opportunity to be able to tackle any issues that patients have rather than letting them linger. So the majority of practices do have them, but we do have some that don't have a PPG and they don't have to under their contracts.
Thank you. And do you want to come back? I think I've seen an email previously from Dr. Johnny McMahon suggesting to councillors they may want to get involved with their PPGs, and I'm sure he would welcome reminding people of that. Richard Cox.
Thank you, Chairman. On communications, I'm very mindful to think that we are probably still a good generation away of people being adapt to digital and online and so forth. And it concerns me in particular because they're the people that actually probably want that instant phone call and so forth for reassurance above anything else. And it seems to me that we're always going to be adrift from trying to address those that probably do really need that help. I've got an instance where I've had a response from a resident of mine that has a surgery actually that's in Councillor Jessel's area that you might want to have a look at, where it took 3 weeks to communicate back to the patient. When it finally got back, there was an apology from the GP, but there was an immediate referral to hospital. Now that in itself in communication is very, very poor if you're trying to rely on service, because that's what you are, a service provider. And I think that something needs to be done there. And I've got some other points there that can be brought forward further in the debate. Thanks, Chairman.
Thank you for that. I think the practice that you refer to, I won't discuss that here, but there is a particular issue that we've had with that practice and supporting that practice. So I'd rather not pick that up now. But I think your question is, are we providing a range of access, be it digital, face-to-face or telephones, to suit the individual? I think that's perhaps a question. One of the programmes of work we have in terms of the access plan is tailoring or personalising the conversation with every patient. So people with hearing difficulties, a teleconsult is not going to be appropriate. Somebody who's frail and complex, we need to see those patients, bring them in and have that eye contact. So although we have got triaging processes in place, and in terms of who and how people are seen in practices, it has to be about the individual and it has to be personalised, and that's part of the training for our receptionist staff to be able to make that assessment and that judgment. Hope that's answered your question.
Thanks, Lynn. That's great. Richard doesn't want to come back. Dave, I want to try and move on to some of these other action areas. So briefly, please, David.
Yeah, the Access Improvement Programme, Area 2. I have the misfortune to be a patient at a practice which seems to have locked itself away. They've got 8 GPs. You cannot make an appointment with a doctor. You can only see either a healthcare assistant or a nurse. I've even got the nurses now saying to me, will you do something about this, please? There are issues, major issues with this practice. 8 GPs, where are they? What are they doing? When it comes to comms, staff abuse, I've got vast experience of training people in dealing with violence in the workplace. Primarily, people lose their cool when they are ignored or frustrated and therefore receive a lower quality of service than they expect. That's why they get very angry and resort to violence.
I think that's helpful, and I do understand the frustration that people are feeling in terms of the long waits. You can see from the slide that I presented to you, the vast majority of appointments are with a GP, so it shows a proportionate split in there. I think it's about 70% are GP appointments. Maybe offline, counsellor, if you could let me know this individual practice. I could probably guess which one it is, if I'm absolutely honest, but if you could do that offline, I'm happy to look into that just to make sure. But in terms of the violence and aggression, I think I do understand people are frustrated, but I don't think it's ever acceptable. And I think that's the message that we have to get out, that we need people to be patient. And certainly any violent aggression is not tolerated. We've had some quite serious incidents that we wouldn't believe, and you don't see people in supermarkets getting this level of treatment. It's part of the approach, really. It's a zero tolerance to that.
I understand your emotions on that, but you have to take very firm measures to prevent the violence. I don't see any security measures imposed at any practices in Lichfield.
We have got a plan around that as well, in terms of additional security that we've bought for practices as well. So that's another conversation, but we've bought CCTV, security alarms and things like that. I think most practices have a panic button as well. So another conversation is not within the presentation, but we have got, obviously, that built in.
And thank you, Lynn. Clearly, we wouldn't condone any violence against staff. They're there to help the general public rather than anything else. Last one on this area, Daniel Maycock.
Thank you, Chair. I'd just like to apologise for being slightly late this morning as well. I'd just like to challenge you a little bit on the 70% of GP appointments. On the slide, there's no breakdown of associate physicians, where in my experience, a lot of GP surgeries use a great deal of the appointments that they have with associate physicians. So it'd just be interesting to see the actual them within that slide, because I don't think 70% is really representative, and I think you've put the associate physicians in with the GPs. Just going back slightly onto slide 5 as well, where you've got the other healthcare professions, it'd just be interesting to see the balance across Staffordshire where these healthcare professionals are, whether it's situated in one region and not another. Thank you.
No, that's helpful. Thanks, Daniel. I can go back and check this, but we have very few physicians associates, probably around 20, I'm guessing, compared to 500-600 GPs. So if they are included in that service line, it's a very, very small proportion. And it may be that in your particular practice, they do have a greater proportion of PAs, but it's a very small number comparatively. I do have the breakdown by appointment by every single health professional, so we can go back and look at that. Hence why we can go look at a practice level where we have got very low face-to-face and we have got very low GP. So we can do that assessment, and we do that. In terms of the breakdown by PCN, all of our primary care networks, these are PCN level appointments. So every practice doesn't appoint these roles. It's basically on a shared arrangement. So the practice is working together to. So in terms of where they are and which practices they are, I could go away and do that piece of work as well. And I think that's answered your questions, I think.
Thank you, appreciate that. Daniel, do you want to come back?
No, that's fine, thank you, Chair.
Okay, can we move on to, just bearing in mind time, can I move on to action area 2? And please ask tight focus questions, guys. Keith.
Thank you, Chair. My one's really a question about setting some idea of targets, objectives and all things. I know that's probably what you don't want to hear at this moment in time because of what's happening. And in fact, even trying to get this whole process up and running is going to be a challenge, and I can see that from what you've been reporting this morning. But the idea of having something in mind might well help sort of pinpoint those things and those areas that you need to concentrate on, which might, because of the limited resource, assist in the idea of improving communication, access, and using digital elements to try and help you do that. By having those objectives, you'd then potentially set up what you need for training and development. That should then improve quality and reduce your workload. There, I've sorted it out for you. But I just thought, I'm not teaching you to suck eggs here, probably, but there you go. I thought I'd try and get a little bit of a smile on your face. So, as I say, I just think that it would be nice for us to know where you're heading. Do you see what I mean? Because without that, I think it would be difficult then to communicate that, not just with the doctors, but also externally, both through us and through the communications back out to the general public. And if they understood that, that might just help reduce the abuse and everything else and give them a little bit more, idea of what might be happening in the future and how you might improve on all this for future of the NHS and the delivery of services. One other little quick comment is, with digital and everything else, in terms of, could you let the patients have a bit more control about getting their own referrals sorted out, rather than having to rely on 5 or 6 middlemen, which has definitely been something that I've picked up on personally, but also I've been hearing about from some of my residents. And it seems to be this very long-winded process of shopping out there and doing other things and all the rest of it, which is fine. But the people that have been successful in referrals, from what I can see, are the ones that have picked it up themselves and supported the practice and tried to go past the practice boundary. So that was just a secondary element. So the first thing is just the objectives. Thank you.
I think that's a really good question, because actually what I've learned from the vaccination programme is that data drives everything. It drives performance, it drives peer pressure, it ensures that you're not leaving anyone behind in terms of inequalities. And that's exactly the approach that we need to take with general practice. So we use the data to drive improvements, and then we set our targets and goals so we can actually see if we've actually done it. For me, that is the strategy. You can see from the slides we've got a lot of monitoring data that we do, but we need that overall picture, I think, for the whole of the county. What I will say is, practices have, in the past, have kept their data very secret, if that's the right phrase. We need to be really open and transparent with the data. We need to share data between practices and with the public, but it needs to be cleaned up first. So we're going through a data validation exercise at the moment that's a national programme, but we've also got a local programme of data cleansing, if you like, so we can be more consistent, so we're not comparing apples and pears, which we quite often are. So that really will drive our programme going forward. In terms of the middleman, I'm not quite sure of the point, if I was honest. Do you mean in terms of people managing their own care and taking forward referrals into secondary care? I wasn't quite sure, sorry.
Yeah, precisely. That was what I was saying, is that some people, it might be more advantageous to them rather than GP practice from driving it, because they've got the objective to get to the end point themselves. You know, waiting for months and months and months for the GP practice to do something which they then don't do is not right. But anyway, I'm going into other grounds there. The other thing I wanted to try and do, that was just a comment, is that what you've just answered is really that it sounds like you need some training into GP practices to allow you to be able to access the information on this digital journey to then try and improve the quality of services throughout Staffordshire. And for them not to communicate with you means that you're not then be able to work with us to improve services. So, as I say, I think you've hit another nail on the head there, is that we somehow need to get GP practices to be happy to share information with them to improve the overall service.
I think we've moved quite a long way forward, actually. To be honest with you, we've got a team of data quality facilitators, the DQFs, that actually work with practices to improve their data quality. But we've got an agreement with our practices now that we can do queries across the whole of all of our 146 practices, so they can actually look into the data collectively to be able to look at, I don't know, cough indicators for just think of something AF or something like that. We can actually do that review from a quality perspective, so we're getting a lot better. But I do think we could really maximise the data around, you know, population health management approach. Where should we prioritise our resources? And practices need to be able to manage that themselves as well.
And Angela, please be brief.
Thank you, Chairman. Really, I want to take to page 7, if that's okay. Am I okay on...
We're going backwards rather than forwards, and given the time and the subject matter and the agenda.
Well, okay, can I refer Lynn back to she talked about workforce on page 7, and she never mentioned anything about mental health practitioners. And I do know there's a big strain on the Midland Partnership Foundation Trust. You know, they're really worried about staff, and I just wondered what work you are doing in that area. And the other question really is to do with pharmacies. Now we're signposting patients to pharmacies do they get any extra training or anything? They're not doctors, and I just wondered if there was any work done in that direction. Thank you, Chairman.
Okay, I'll be quite brief. Thanks, Anne. So in terms of the mental health practitioners, we've been working very closely with Combined Healthcare as well as Midlands Partnership Trust around training and appointing mental health practitioners at a PCN level. I think you're absolutely right, though. The whole of the NHS is facing a workforce challenge at the moment. So what we need to do is make sure that we're not paying Peter to rob Paul and moving staff around and leaving people short. And that's part of the workforce hub, helping us to coordinate that. So we've had a similar situation with pharmacists. So my medicines team, we've actually worked very closely with the primary care networks to transition staff across rather than facing losing staff. And we've had to do that in a very concerted way. And the same goes for mental health practitioners as well as some of the other new roles like physios. In terms of the community pharmacists, the new integrated care system will become delegated to manage the contracts for the other primary care contractors, so pharmacy, optom and dental, over the next sort of 12 to 18 months. Pharmacists are currently commissioned by NHS England, but we work very closely with NHSE and increasingly more closely with community pharmacists at a network level so they can build relationships up. The referral scheme that we have in place, though, is very specific. So it's a number of conditions that can be seen by a community pharmacist to which they're trained for. So it's minor eye procedures, skin rashes and things like that. But it's a very specific scheme. So it's not a case of everybody going to see a community pharmacist, because you're quite right, they wouldn't be qualified to do that. It's specific conditions that they can manage.
I'm going to move on because we're going to miss out on time. Richard, very briefly, please.
Thank you. It is very briefly on action area 2, Chairman. I see that the first action is to promote the Access Improvement Programme in practicing, ongoing until the end of March 2022, and then notes disappointingly see only 14 practices currently engaged. So what does this tell me? I'd like to probably ask the question, when did you actually start the process in terms of access improvement? And I think you alluded to the fact that some practices won't change. What are the barriers that are presenting you that obviously really address the situation of GP access? Thank you.
I think
Lynn,
The barrier.
sorry, Lynn, you've touched on some of this with your answer to Philip Atkins. Can you just focus in on the barriers, please?
Yeah, so the barriers is the unprecedented levels of demand that we're facing at the moment. We've got a flat workforce that is struggling to meet that demand that it's faced with. You can see from the slides, it's equating to around between 20, 30,000 to up to 70,000 additional appointments. That's not sustainable, and that's the main barrier, really. The Time for Care programme was initiated in September, and we have got 14 practices engaged. We have got all of our practices have been taken really well to the programme. You can see the audit received 112 responses. For me, it's a timing issue. The unprecedented levels of demand, the social distancing that still applies in practices means we can't get patients through. And now we've got the added pressure of a vaccination programme, and it is a big ask for practices. We cannot deliver the programme without them. So they've got additional workload that they're also being asked to take forward as well. Hence why things like the Time for Care programme isn't being prioritised at the moment, but it certainly will be going forward. Practices value that support.
Useful, thank you. And last one on this area, Daniel Maycock.
Thank you, Chair. Just like to draw your attention to Area 6 with the training and development.
Sorry, Action Plan 6. We're not yet there.
Okay, sorry, Chair.
I'd like to try and get there. It'll be okay. Let me just ask a question I have, please, Lynn. Area 2. How do you identify unmet demand or unmet need, particularly from those most vulnerable and furthest from being able to access into the system?
So this is where the data really helps us, Chair. So as you saw from the last slide, how will we know? Each practice has a range of indicators that we monitor. So you would expect to see those practices with unmet need that have got low uptake on their disease registers. So they may, I know there's some practices in the Cannock area that 2 standard deviations away from where they should be in terms of COPD. So they haven't got enough people on their registers with COPD for their population. So that would show they're not identifying, or people are not coming forward and having their being diagnosed and then being managed. So we use the information to identify where we might have issues, where usually in places of high deprivation as well. So we use it as a sort of population health management approach. So we can look at the whole patch and see where our hotspots might be, and then drill down into that to understand is it a practice issue and what we can do in that individual practice.
Really useful, thank you. Action area 3 is about record keeping. I'm not getting any indications, so I'm going to move on to action area 4, digital solutions. We've talked a bit about digital. I'm not getting any indications, so that moves us on to action area 5, quality, variation, and resilience. So just let me ask a quick question then, if I can, please, Lynn. If you're looking at root causes on some of the variations, when do you think you will get to a point where you've got all the root causes nailed down?
I don't know if we'll ever get to a point where all the root causes have been nailed down. So as you can see from the slide, some of the unmet need might be high A&E attendances. It might be overprescribing of antibiotics, for example. So because we're looking to range, what we would do is prioritise those most important at a given time. But there'll always be practices that have certain issues that might mean that they are struggling with capacity, and there might be a knock-on effect with A&E, for example. So I think it's an individual practice by practice issue. I think there'll always be outliers, if that's the right phrase. There'll always be some outliers, and that's about continual improvement, isn't it, and using the data continually.
Thank you. Really useful. David Latham.
Yeah, it's action area 5. Patient participation group. On the particular practice I'm referring to, and I think you've got it probably guessed by now, Lynn, it talks about receiving awards for its PPG, but unfortunately there's no activity on the PPG since 2012. they're living on past glories.
It's quite interesting. Again, if you can let me know which practice this is outside, I can look into that.
Thank you. Just in terms of Action Area 5, Lynn, I noticed that there are some patient surveys going on and some group work looking at health inequalities. Will you be able to share, an outline summary once you've got to reviewing all those and that data, please? Just really interesting for committee to keep on in line of sight.
Yes, sure. And we work with Health Watch in terms of those surveys as well. So again, we've done that something jointly. But yeah, I'm happy to come back when you'd like me to, Jeremy.
That's brilliant. I'm going to move us on to Action Area 6, Training and Development. We've talked a bit about this already. And you might as well do Action Area 7 as well then at the same stage, please.
Thank you, Chair. Just touching on Area 6 and possibly Area 4, you speak a lot about training and development of staff and maybe how they're putting digital services into their practices. But a lot of the anger is about patients not being able to get to their GP, to have appointments with their GPs. And part of that might be because they may lack a bit of digital literacy. So maybe an action in there could be looking at how you may be able to educate patients on how to use the services that the GPs are implementing, really.
I think you've hit up an important point. I think when we've changed the new model, largely during the pandemic around, more remotes, the different workforce that patients can perhaps access, I think we were slow off the mark because we were in a pandemic to say, and actually, this is your new practice team. This is how they can help you. But we've started to rectify that now. So we've got a number of videos that we've to introduce the new practice team, and I think that's really important that we do that because people just didn't know. They want to see a GP because they don't know there are alternatives. In terms of digital, I think perhaps be surprised. The majority of people, it's 92% of people have a smartphone, and the feedback I get from GPs that most people, even a lot of the time it's well, perhaps older people can't use smartphones. They can use a telephone. So, but I think it's about tailoring that approach to the individual, and that's where the training comes in to make sure the right professional in the right setting sees the right patient. Hope I've answered your question there.
Do you want to come back?
I think you're missing where you said you're going to show, you've got videos. How are people accessing these videos? If it's in GP surgeries on their TV, people aren't going into GP surgeries. So how are people seeing these videos, training videos as such?
So they're all available online. So we've got YouTube videos, we've got links on our website. We use the social media from our practices because most people don't access the CCG website. They will go to their local practice social media or Facebook page. So really pushed social media in the last few years, and every practice should have a Facebook page now that they can get messages over to patients and gather feedback. So we do it in a number of ways, but we recognise that paper's important as well. People still do like to have leaflets and don't always access the media. So we've made sure that we've got a range of options for patients. Meet the practice team. We could put some leaflets. Unfortunately, we'd have to put these in practices themselves, but yeah, there's lots we can do with our own comms. I think we need to do more.
Thank you. I've got a whole long list now. David Latham.
Yeah, thank you, Chair. I live in a village which has the great fortune to have a superb pharmacy, largely, purely because of the skills of the pharmacist. She's employed by a group that runs 6 different pharmacies. She's been moved out, and the village population is already in uproar because the quality of service has dropped dramatically since she's gone, and she's only been gone a few days. The business is run on business lines, but we've got talks about deputations and petitions and all sorts.
Sorry, can we keep that of individual pharmacies? I mean, yeah, I think this is very focused on one pharmacy. I think we should
I don't want to focus on one pharmacy. I just want to get perhaps a message put across that pharmacies are businesses, and businesses can be run in whatever way they wish to be run. But the public believe that they've got a right to express protest about a business decision. Who has the final say on what's right or not right with pharmacy moves?
In terms of pharmacies, they're commissioned currently by NHS England, so that would need to be raised with the NHS England team. But from the 2023, I think it will be delegated to the Integrated Care Board, but currently it's NHSE.
Thank you. Angela.
Thank you, Chairman. Well, we all know we've all got problems with, with people complaining about access to doctors. And the problem is, Lynn, it's going to get worse because the population is growing. You know, in Stafford alone, the amount of people now coming to live in the area and that, but that we don't see any improvement in access to doctors. But no no more doctor surgeries being opened or anything. I mean, I sat in the planning committee only the other week and we got 2 separate applications, one with 400 houses, one with 356. Now, my understanding is that, you know, we can't ask for any intervention from health because it's not 500 in the application. So how are we going to improve that if we've got a problem now? Thank you.
Thanks. I've got 3 points, if I may. I suppose the GP Forward View in 2016, the Conservative government announced that we would have 5,000 additional GPs trained and recruited by 2021. We are 1,300 fewer GPs now than we were back in 2016. So we've got a real problem. There just isn't enough GPs. It's a national problem. It's not a Staffordshire and Stoke-on-Trent problem. It's just there aren't enough GPs, which is why the government has responded to complement the team with the additional roles and trying to bring new workforce into the market. But I need to be really clear, there are no more GPs. We've got quite a good complement in Staffordshire and Stoke-on-Trent. Believe it or not, it's quite an attractive place to work, despite some of our challenges. So we did a campaign that that read along the lines of a few years ago that actually we're in the middle of, it was Manchester and Birmingham, so the access routes out were quite good, but that's something that people wanted. So yeah, the problem is nationally we were promised GPs and they haven't come forward. So for ourselves in Staffordshire and Stoke, we've probably got around 100 fewer GPs than where we were 5 years ago. That's what it translates to. Our previous primary care strategy, though, was to optimise the practice footprint, so not necessarily to pop up lots of different practices. So 5 years ago, I had 172, now I'd have to check that practices, and we're down to 146. We've merged them, we've closed a few. Our practice list size then was 6,400. 5,800, sorry, we're near 7,000 and 8,000 now. It's about 8,000, sorry. So we're making our practices bigger, not making lots of smaller ones, if you like. And the reason for that is we want to make sure that practices are resilient. We are moving away from single-handed partnerships, for example. That said, I recognise that Staffordshire the population is growing. We've got some very key hotspots down in Burton, Cheadle, Lichfield. South of the county is sort of the Birmingham spread happens. The planning, we've been working with the planning teams for some years, but we haven't had a resource to manage this. It was taken away when PCTs were disbanded. That said, I've just appointed into my team 2 project officers and planning officers who have got the capacity and the experience to take a helicopter view of the whole of the patch to understand where we need to start working with developers to develop new sites. So that's something that we're working very closely as a system on. Paul Brown, who's our incoming finance director, he's the chair of the System Estates Group. So primary care needs to work with the wider system in terms of the buildings, if you like. But we are certainly looking at optimising the footprint, not necessarily having more practices. That's a slight anomaly there. I can see it's slightly different, but yeah, we do need to grow our practice footprint to give them that resilience, really, rather than the other way around. But, you know, we are looking at, it's easier to manage a practice site on one site as well, especially when you've got a multidisciplinary team. Branch surgeries are less efficient to run, and it means that you're having to split an already stretched workforce. So we don't necessarily want any more new buildings.
Thank you, Lynn. I'm going to bring in Martin Buttery, and then the last person on this will be Janice.
Thank you, Chair. Just referring to Action Area 6 training, training for receptionists to support call handling and challenging points. It says in the notes a series of conflict resolutions and de-escalation training has been offered to staff. 174 places available, a majority have been taken. What are the numbers? And these 174 places available, as we know over the next 3 weeks with the new booster programme rolled out, the access to GPs is going to be probably even more stretched. And what is the actual take-up by the receptionists and staff at these practices?
We've used all 175 spaces of the first courses that we've run, and we've got some really positive feedback from the practices, and we're putting some additional sessions on to support frontline staff. But this will be in the new year now, so we've had good uptake. All of our practices have come forward. We can put another 175 places on available in the new year, and happy to feedback what that uptake looks like. But really positive response about them.
Thank you. I'd like just to finish with Janice.
Thank you, Chair. A couple which I'll try and group together, and hopefully it's encapsulated in some of those. I'm trying to ascertain, how do we know if patients are being offered the most appropriate appointment for the patient as opposed to the practice? And referring back to, I think it was in the June-July minutes, there was a close review of the consultation dashboard that was mentioned. And I wanted to know what the outcome of that was and how it's shared, and if that could be of any use to the public as well. Thank you.
Okay, thanks, Janice. I'll take your last question first, if that's okay. There's been the national plan around access improvement over winter was around, and I'll use the phrase that was used at the time, naming and shaming those poor performing practices. I think that's very dangerous to do that, particularly at the current time where patients, we've seen quite a number of acts of aggression towards individual staff. So in terms of that dashboard, we regularly monitored that. It's something that the primary care team with the clinicians review on a monthly basis, and it's those 61 indicators on a practice-by-practice basis. We take action every month when there's any area that's of concern, be it prescribing, for example, or low register uptake rates. So it's very specific. So it's not something that's in the public domain, although we do share practice level data between practices so they can have that peer review and challenge and discussion. But it's not something that we share widely. And certainly the GPC nationally challenged the government position on that. That's out of my hands. But for me, while we do need to be open and transparent, there's some data that we don't necessarily share in the public domain. I think that's a really good question around how do we know it was the most appropriate appointment? And I think that's a piece of work I'd like to go away and look into. There's something about the patient survey, about satisfaction rates at a practice, and we can obviously pick it up there. We obviously pick up soft intelligence around individual practices as well. So we don't have a formal mechanism for monitoring that, but there's, as I said, a range of indicators that would tell us that. So again, that's something I'll take away.
Yeah, thank you for that. I think that would be helpful, and I think in conjunction with the 360-degree work that you're doing as well, that they may also become quite a useful piece together. Thank you.
Thank you, Janice. Sometimes the most interesting questions come at the end, so apologies to Richard and to Philip for guillotining this session here. So just let me summarise where I think we're at. Certainly I welcome the data and the detail which is in these reports, so thank you for that. Certainly support the comments, and I'm sure everyone in the committee does, in terms of zero abuse on staff. I think we're not at a conclusion. It's still very much work in progress. I think you would probably say that. But I appreciate the work that you're doing to let data do the driving of the plan and the focus. You talked about a vision earlier, about a future plan and a universal service, and I think those are areas that we would like to come back to in due course. You also just talked a bit about KPIs, and I think that's sort of still work in progress for us in terms of what we would like to see going forwards. And I think there's a piece that we'd like to come back to which looks at, is the estate fit for purpose? And Philip's mentioned this a number of times, and I think it's a valid point. And those are all key areas that we've talked about about this morning. Lynn, thank you and your team for this morning's session. Thank you for all the papers. Thank you and your colleagues for the work you're doing. And obviously, we'd be pleased to see the vaccine plan once you've had 5 minutes to be able to go and create that one again as well. So thank you.
Thank you, Chair. Thanks.
So, committee will move on to item 4, which is the report on urgent and emergency care for Staffordshire and Stoke-on-Trent. Simon, I think you're leading us away. Can I give you 10 minutes, please?
Thank you, Chair. You can, absolutely. And we've got a short presentation, but hopefully, colleagues, the paper that we put together for this item was really detailed and provided a significant amount of background and update. My starting point just goes back to where you started this morning, Chair, if that's okay, though. Look, I want to recognise, and I'm joined this morning by colleagues from across the system, from across providers, ambulance service, University Hospital North Midlands, University Hospital Derby and Burton, CCG colleagues, GP colleagues, Royal Wolverhampton Trust. So there's a significant number of people on the call this morning to provide that level of background and context to the detail of this paper. My starting point, though, as I said, is just to recognise the amazing and fantastic work that our frontline staff across the board in all settings are providing at present, have continued to provide through the pandemic, and as the Prime Minister asked last night, we're asking them to go again. And that's a really difficult place for colleagues, given the challenges they are facing, but they are absolutely standing up to that challenge, and really important that we start with a thank you in that space. The second bit is to recognise the importance of getting this right for the population that we serve. So we've already had a long conversation about general practice access and the impact on local residents. I think there's a really important message to say, yes, we've got a real challenge against the variant and against making sure that we maximise on the boosters, as talked about, but the NHS remains open when you need it, and that if you've got an urgent need for NHS care, you need to come forward and present, and we need to make sure we get you that timely access and timely treatment. But for some care and for some treatments, there are really long waiting times. And that leaves local residents in pain, in discomfort, and for that we apologise, but we are working really hard, and frontline staff are working really hard to meet that priorities as they come through the door. So we've got a short presentation, and if somebody could put the slides up, that would be great, please. Thank you, Alana. Move on to the next slide, please. So this is set out in the paper, and you've touched on some of this already, but significant demand, real ambitious challenge in terms of the vaccination and the booster programme and the flu vaccination programme, demand across the board, social care, general practice, secondary care, mental health services, ambulance services, and a real impact, as I've already said, as the bottom bullet point says, in terms of on frontline staff. Next slide, please. The slide really highlights some of the detail that's in the paper around the demand that partners are seeing across the system. I think there's a really important point in here, though, which is about the ability and the willingness for partners to have worked collaboratively, to have worked together, to look at how we best meet and respond to the challenges that we've got. System partners have been working well for a number of years, but we've all seen the benefits of that during the initial COVID response. And in terms of how colleagues have come together to work to support some of the really significant ambulance delays, some of the delays in terms of discharge and flow through the hospital, we've seen partners work really well together in that space. The way that we've structured our approach, as you've seen in the report, is into three main work streams: pre-hospital, in-hospital and discharge. It's a simplification of the nuance that goes with that, but it just helps us to move away from individual organisations, make sure that the work that MPFT around community and mental health services, supporting social care, is just able to be chunked up, and we're able to break down those organisational boundaries. Next slide, please. In the paper, we go into significantly more detail about this, and you've already talked a lot about general practice and primary care services. No intention of redoing the work that Lynn and colleagues have just presented. But certainly, I would imagine you'll want to come back to some of the ambulance service challenges. We got colleagues with us from the West Midlands Ambulance Service here this morning as part of that partnership response. Some of the delays have been significant, but people have been working really hard to try and support that flow of ambulances. We know that keeping an ambulance sitting outside any of our emergency departments stops it from being deployed to the next call, and that has an impact on patient care. But we also know in hospital that we need to make sure that we're treating patients safely, and we've got the flow through hospitals in a way that makes sense, so that when somebody moves into an emergency department, they're able to get the access to the care and the diagnostics that they need to enable that ongoing management in a safe way. So this is a really difficult balancing act that we're trying to refine and work through all of the time. Some of this, of course, is about how do we make sure the right people are able to get the care that they need outside of hospital without ever needing the ambulance to take them there. And there's been some really fantastic work done with both the ambulance service, with the community rapid intervention service, and with NHS 111 to really make sure that we only take people to hospital that need to go to hospital. And Staffordshire and Stoke-on-Trent is being identified for the positive work it's done in that space. Next slide, please. I've touched on this a little bit, and colleagues from the Acute Trust that are with us this morning will be able to go into more detail on this when we get into the conversation. But the work to support the flow through the hospital to prevent unnecessary delays is really important and is ongoing. Where colleagues have worked really hard to look at what services are offered at the front door. How do we make sure we've got our senior decision makers in the right place to make the right decisions about referral or admission, and how do we use alternatives to admission? We've already picked up on general practice access, and what does that look like in terms of communicating across partners, and making sure that also we recognise the challenge of paediatric care. So what the impact of RSV on children and respiratory conditions over the past few months and over the coming months, to make sure that our children will flow through services in a way that makes sense. Next slide, please. You will have heard previously we've come and talked to this committee chair and colleague committee members about the COVID response and about the challenges in critical care. And at the same time now, as we are absolutely increasing the booster programme, as you've heard talked about, we're asking Acute Trust colleagues again to go back and look at how do they create additional capacity in critical care for the demand that comes through over the coming months. The challenge here, of course, is we want to keep as much elective surgery going as we possibly can for those priority patients that need that intervention. But some of those patients will require critical care beds post-surgery. So that's the reason that we want to try and make sure we've got the right capacity in place to get the right balance between the services that we restore, we give people the surgery that they need in a timely way, but we've got the capacity to respond to the urgent and emergency care pressures as we come through the winter months. That's a really fine balancing act, and one that we will need to continue to revisit. What we can't afford to happen is to find ourselves in a situation where we just don't have the critical care capacity to meet the challenges of patients presenting through urgent and emergency care. So a lot of work around that, and again, significant detail on that in the paper. Next slide, please. And you've got a social care presentation shortly that will go into this in more detail. But the work to make sure that we get the patients out of hospital, how do we keep people supported in their own home for as long as possible? The real challenges that we've seen in the domiciliary and the home care market are really significant in terms of the pathway and the flow through this system. So partners are working really hard to make sure that we've got significantly reduced delays where possible, The list that's called the medically fit for discharge list is looked at in real detail, and people work on that on a daily basis to try and make sure we get the right people discharged in a timely way and supported at home. But I can't sit here on behalf of partners and say that that's working as well as we would want it to do. And there are real challenges in that domiciliary and that home care market that you'll hear presented about shortly. Having said there's challenges, people are doing everything they possibly can to try and make sure we're making the right decisions for Staffordshire residents in terms of their care. Next slide, please. And so this links to that in terms of discharge to assess, in terms of home first services. We've talked about, and you'll pick up the use of NHS money to try and support that social care and domiciliary care market, looking at the workforce and looking at our challenges, looking at discharge to assess beds and what capacity is available to us, and also what flexibilities there might be around that discharge process. And Chair, you mentioned right at the start, the national document was attached, and again, absolutely correct. This is not about saying let's get into the rights and wrongs of national policy, but we've just felt for committee members it was a useful appendix for people to see what the ask is and what that looks like and what that means, not to get into scrutinising that, but how does that become applied locally for Staffordshire residents. I go back to what I said right at the start, though, in terms of one of our biggest challenges here is our workforce challenge. The workforce of having the right number of people, the workforce of what that means in terms of what we've already asked them to do and what we're asking them to do again, the workforce challenge of community, social care and domiciliary care against hospitality opening up and against the workforce challenges and recruitment challenges that go with that, and against a workforce challenge of making sure we've got the right clinical and professional staff in the right place to make good decisions for the ongoing care for the residents that we've got responsibility for. So next slide, please. So, Chair, I'm hopeful that I've not taken 10 minutes up because we'd rather spend longer in conversation, given we've brought so many experts and so many colleagues from partners with us this morning, which we'll try and navigate through that. And hopefully the paper was detailed and comprehensive to enable people to really look at the work that's taking place and the work that's happening and the approach that's been adopted with system partners to be in as robust and strong place as we possibly can be, recognising the challenges that we're facing. Thank you, Chair.
Thank you, Simon. Appreciate that. First of all, congratulations on your appointment, and equally thank you for all the work that you've done within Staffordshire's STP over the last few years. We really appreciate that, and thank you for pulling together today's presentation and for rostering the partners we have around the table this morning. So, where do we want to start? Shall we start in the sort of logical flow that Simon has identified in terms of pre-hospital, then in hospital, and then discharge? Philip Atkins.
Thanks, Chairman. And I'd first of all like to say congratulations, Simon, on your new job in Shropshire and Telford. It's our loss. It's been a great pleasure.
Thank you, Councillor Atkins.
Yeah, it's been a great pleasure working with you over the years. The paper's really good. Starting on the pre-hospital bit, and understand the problems, and everybody in on the call, you know, and the issue seems to be that the public see, you know, you talk to town council, which isn't in my area. I know I represent you talk to rural. The villages are different to the town. They've been upset about the ambulance post being moved, and I know that there isn't an ambulance post. The ambulances move around, but there's the ambulance service are then in the position that they can't get people in because the hospital's full. Then the papers are full of stuff blaming social care for not taking people out of hospital. And I know it's a really complex thing, but the previous item was quite key to it, about people having a bit of personal responsibility rather than this feeling that they're entitled to everything there at an instant. And I know what the problem is for those on the call. So I'm just wondering if with my background in farming, we do an awful lot about hazard analysis, critical control points. which is that you can go on about ambulance service or social care or if you've got to delay operations to make room in the hospital for people who've slipped over on untreated streets and broken their legs and arms or whatever it may be. So, you could say gritting the streets is key.
Absolutely.
To keeping hospitals empty, And it's what are the real critical control points that need attention in the coming months, because we're just at the start of the hospital's worst time for hospital discharges and waiting times.
Thank you for the kind words at the start, Councillor Atkins. So, look, I'm going to ask Mark Doherty and Murray McGregor just to come in and give an ambulance position at this point, if that's okay, Chair. So, Mark and Murray.
So I'll come in first, and Murray can pick up. I think the question's quite a complex one. In actual fact, I'm sure it could be the subject of a PhD thesis. I think what I would do is I would focus on some facts as to where we're currently at. So in answering questions, I think I would pick up the Chair's initial point. This isn't about individuals or services, because everybody is working their damnedest to try and deliver the best service possible. But the fact of the matter is, at the moment, we've got significant handover delays in Staffordshire, particularly at the Royal Stoke site. The Royal Stoke site, as far as we're concerned, we're losing more hours due to handover delays there as things currently stand than any other hospital in the region. So the Royal Stoke site is consuming 16% of the time lost due to handover delays out of 22 emergency departments we go to. So I think the first thing to recognise is we have got a significant challenge there. Now, the challenge partly is due to the Royal Stoke being pretty much surrounded by rurality. So unlike many areas, so if you go into Birmingham, we've got a number of different hospitals we can divert and move resources to and from. The Royal Stoke doesn't have that sort of privilege in that, particularly out of hours when the Stafford site is closed. We haven't really got a lot of choice where to take patients if they need to go to hospital. So that's one of the challenges that we face in Staffordshire for our patients. But what I would emphasise, there's a lot of positive work going on. So the CRIS service, which is the Community Rapid Intervention Service, which has been up and running for a while, but now is really coming into its own, is a really, really good service for attendance avoidance. And actually, I would hold that up as the exemplar that every single region needs to copy. And I say the word copy, I think this is about recognising what's good. So in Staffordshire, we've got conveyance down in North Staffordshire, where the CRIS is operating really, really well, down to below 37%. So roughly 2/3 of 999 calls we get in the north of the county, particularly, don't go anywhere near an acute hospital. That's the highest non-conveyance in the whole country. So that service I would put as an exemplar. The disappointing thing is, despite that, we've still got the longest handover delays. So we've got to find other things. In my view, when I work on ambulances in Staffordshire, and actually across the region, because I don't think Staffordshire's unique in this, there is a very, very high number of calls that we get where an ambulance wasn't necessary. Now, that's easy for me to say because I'm an experienced clinician, but patients call 999, sometimes what we would class as inappropriately. But when you talk to the patient, they've often tried lots of different things. They've maybe tried the GP, they've maybe tried the pharmacy, they've maybe tried a lot of things. So the question I would pose is, if your frail elderly relative falls out of bed at 3 o'clock in the morning, what services are around to help them? And the answer is, wherever you go in the country, there's not a lot. So very often the ambulance service is used as that sort of gap filler for a lot of the services that are not present in other areas. I'm going to pass over to Murray now, because there's probably a lot more, particularly by way of how it's articulated, that he can add to this.
Good morning, councillors. I mean, I think the closure of the Toxter, Leek and Biddulph sites was a very difficult one, but it was necessitated by the issues that we face. Ultimately, because we're losing so much time, we had to do things to try and increase the amount of ambulance time available. And effectively, by closing those 3 sites, we put the best part of an extra ambulance on the roads 12 hours a day. And that's the level of waste that was going on by having those sites open. So we are trying everything possible, as others have said, to get to patients as quickly as possible. But as Mark has said, it is very, very difficult at the moment. But I think, you know, having done a few of these committee meetings around the region in the last few months, I think there is a lot of positivity within North Staffordshire, particularly with the CRIS scheme. And we are starting to see other areas look to the CRIS scheme to roll that out, because they see that as being such an effective scheme in stopping patients ending up at A&E. I don't think I've got anything else particularly to say at this point, but clearly very happy to take any questions.
Thanks, Murray. Thanks, Mark. So Paul and Duncan and Simon, anything that the 3 of you would like to add from the Acute Trust perspective?
Chair, thank you. I'm Paul, by the way, the Chief Operation Officer at Royal Stoke and Stafford. I mean, not really. I mean, I guess we have talked about the challenges that the system are facing, workforce dependent, occupancy dependent. The hospital continues to operate at Royal Stoke about 97-98% occupancy, working with colleagues in the system to try and reduce that as we head into winter. Lots of really great ideas to try and support colleagues in the ambulance service, and we will continue to try and work with the ambulance service to get ambulances back out on the roads, because we all recognise the challenges with this.
Thanks, Paul. Simon, Duncan, anything additional to add?
Just to add, I mean, for me, going back to the previous councillor's question, I think as you go through, the flow is critical. We talk about the flow, but flow is critical at various points as we've identified. So it could be pre-hospital, it could be in hospital, it could be the discharge. If you haven't got the discharge right, then you can't get any patients out of hospital and you'll snarl, or your front end will snarl if you haven't got it right in the hospital. So all points are critical. And if any one of them starts to fail, you'll struggle.
Thanks, Duncan.
Yeah, it's probably a reiteration of the two points that Duncan and Paul have both mentioned, to be perfectly honest with you. Resource is our #1 challenge still. It's ongoing. Inability to recruit to the right staff groups at all levels means that we can't necessarily get the system working as efficiently as we would like. And then, of course, the problem we see at the front end is largely dictated because of what's happening at the back end of the hospital in terms of discharge, and then having a wider system conversation, because we know that there are a number of wards that are completely full of medically fit for discharge patients who can't necessarily get to the most appropriate setting for them. So right now it's almost like a perfect storm for us as we head into the harshest part of the winter, actually.
Thanks, Simon. Back to you, Chair.
Philip, do you want to come back?
Yeah, it sounded very much like a conversation I had with Roger Thane about 20 years ago in some ways. Many things haven't changed. And I think one of the key bits listening is particularly about the ambulance use and the CRIS in North Staffordshire and unnecessary calls. There seems to be something about a decision tree almost at a public level, community level, advising people about where's the best place to go, because it seems that they instantly want to go to the GP, and if they can't get to the GP, they pick the phone up and do dial 999 and I want an ambulance, you know, and it's putting pressure on places where it shouldn't be. And then the measures that you've got about delayed admissions and delayed discharges mean that the blame falls on possibly the wrong place. It may be the public need a little bit of communication about how best to help themselves. You know, we've probably all got personal, or we've seen things where the health service has excelled and we've wondered what's going on. And I fully understand the ambulance station bit about freeing up the 3 sites and it gives possibly an ambulance, because That's a conversation I had with Roger Thane in about 1998, I think. You know, so I do understand that you're looking for best solutions, but then you've got an awful lot of work that we could possibly help you with as counsellors and councils in explaining it to the public rather than just being a channel for moans and groans and blame. And I think, you know, we've got an awful lot to do. And I do echo, we're at the start of the winter. As a farmer, February the 14th is the middle of winter, not January the 1st.
Murray, you want to come back?
Yeah, it was just to pick up the point about the public. We did some data a couple of years ago about usage of the 999 system, and it is interesting that the public do use it very differently, particularly people in their 20s. So we now see, compared to around 5 to 10 years ago, the number of people in their 20s using the ambulance service and dialing 999 has doubled. And I think all we can put that down to is that I want it now feelings that everybody has, whether because of the use of Amazon and other delivery services, they can get everything now, and they tend to want their health service now. And that has put huge additional pressure onto the ambulance service, and I'm sure our colleagues in other parts of the health service as well.
Thanks, Murray.
Thank you. And I noticed that if I took those 2,670 hours of waiting time across Staffordshire and Stoke-on-Trent's system for ambulances, that's 89 hours a day. I don't know how I worked it out as 17 crews, but that's what it seemed to work out at. So we talk about some significant numbers, aren't we? And the impact on residents in terms of conveyancing is significant.
Yeah, so to translate those numbers, because I think we talk a lot about numbers, and what we need to remember is behind each one of those numbers is a person's experience. So if you actually have a look at what it means for people in Staffordshire as we speak, if you're a Category 1 patient, first of all, you probably won't know you are because they're generally unconscious, not breathing, no cardiac output. You'll generally do fairly well in Staffordshire compared to the rest of the country. You'll get a response in about 9 minutes, 8 minutes 46 to be exact. And 90% of people will get a response in under 15 minutes, which is very, very good considering all of the delays there are. Where you're going to experience the worst of our service is if you're a Category 3 patient. Now, to give you an example, that could be a frail elderly person that's fallen. The chances are you may wait up to 9 hours. In actual fact, 10% of those patients will wait over 9 hours for a response. Now, those, to some extent, are the ones we should be really, really worried for, because I wouldn't want to be a frail elderly person left on the floor for 10 minutes, let alone 9 hours. And at 9 hours, you're going to have other problems. You'll have pressure damage. You'll probably be dehydrated. You'll probably have messed yourself. If you've got any predisposing conditions like diabetes, you'll be in a very, very serious way. So I don't think we should shirk from the challenge we've got. And it's a system challenge. Let's be clear. It's not aimed at any individual organisation. And I think it's as much a challenge to the council. You know, we've heard of delayed discharges from hospital. So we need people, everybody, to be rising to this challenge. I can't remember if it was Paul or it was Duncan actually mentioned about flow. If we've got a silted up system at the back end, every part of that is going to be problematic. So we do need the council to help, to support getting these people out of hospital very, very quickly, because every patient that's delayed in hospital will result in a frail elderly person lying on the floor longer than they need to. So I think it isn't about finger pointing, in my view. We've done enough of that in the past. I think this is about rallying the troops, rising to the challenge, because we have got about a week to actually start to get some of this traction. Because if we don't, we're going to have a very, very difficult winter. And I accept that I hadn't realised Valentine's Day was actually the middle of winter, but I'm now educated to that fact. So thank you.
And Angela, thank you. And Angela.
Thank you very much, Chairman, and thank you for your presentations. My question really is, why are we using ambulances for a taxi service to New Cross Hospital? I know that for a fact because a lot of patients from Stafford go to New Cross for the eye clinic. And I actually followed a lady when I was there, and she'd come from Stafford and she was in an ambulance just attending the eye clinic. So can you answer that question for me, please? Thank you.
Mark and Becky will probably pick that up, Chair.
So there are different ambulance services around. One is the one that we provide, which is the urgent and emergency ambulance service. The other one is the patient transport ambulance service. So we wouldn't, under the urgent and emergency service, transport a patient for a clinic appointment, but the patient transport service would do that if the patient needs the transport for health reasons. And I guess if someone can't see properly, that's a health reason why they may need patient transport to attend an appointment, because not everybody, sadly, has other friends or relatives that can help them get there. So I would suspect, but I don't know because I don't know the patient details, and it would be wrong to talk about an individual patient on this type of event, but I suspect it would be the patient transport service ambulance. Now, the other thing I want to say at this point is the 111 service is available for people that are confused as to where to go. I have to say, when I have to use emergency or urgent care services, it really, really is confusing. So I've worked in the health service for nearly 40 years and I get confused. So your average member of the public, and they will get confused. And what we shouldn't do is blame them for using certain services in certain ways. What we should be doing is helping them navigate through the very complex services that are out there. And the 111 service is the way in which our health systems, I think, can actually do that very effectively.
Thanks, Mark. Becky, anything you want to add to that, or have we covered it?
No, I think Mark's covered that. Thank you.
Yeah, thank you. Chair?
Thank you, Anne. Do you want to come back? So I'm just going to pick up the gauntlet if I can. Is there a significant number of people who are being conveyanced into acute hospitals who effectively shouldn't be? Does that pose a problem still, or is that something that through triage has been addressed at source?
Mark?
Yeah, so I'll answer that, but I'm sure Paul, Duncan or Simon may have a different perspective on this. So I think based on the evidence that we've done, that we've got, and the audits that we've done, is that the answer is I don't think the number is large by way of numbers that go in that shouldn't go in. That's not to say that we don't convey people that actually, with hindsight, could have gone somewhere else or shouldn't have gone in. If you think the job of a paramedic is actually quite complex, these are people that have to be experts in everything from psychiatry through to general practice, through to social work, through to maternity. They can't be that. So in a sense, they've got to be risk averse. And with the best intentions, they'll bring someone in that maybe could have, their attendance could have been avoided. But I think when you've got conveyance levels of 37%, my concern would more be around people being left at home that should have gone in, because we do know that happens where people have vague symptoms, we leave them and then they deteriorate and sometimes die. And actually, when we look at those cases, the paramedics often say, well, what I might just do in future is just take them in. And that's the last thing we need, because we've got to be risk averse, but equally, we can't be so risk averse that we clog up all the acute hospitals with everybody. You know, a paramedic could not make any errors by taking everyone to hospital, but in a sense that would be the biggest error, because patients would be harmed if we flooded the hospital. So, I mean, I'll pass over to acute hospital colleagues for their views on that.
Paul?
Yeah, thanks, Mark. So, I mean, I guess Mark's right in terms of access. There, you know, the ambulance service bring people to Royal Stoke because there is no other service, as he talked about, particularly overnight. So there is still some work to be done on alternative providers. But Mark, ourselves, MPFT, are working with the CRIS team to look at how we can engage the ambulance service with being able to pass calls to the CRIS and have a 2-hour response time to reduce further that conveyance up to the Royal Stoke site. So, you know, there is still some work to be done. Like Mark says, it's not huge numbers, but actually accessing community-based services from the ambulance service and then from our front door is part of the work we're doing with the winter plan, and also with our urgent care centre partners in Vocare, and we've been looking at how we work with Vocare with a brand new test of change from last week, looking at how we can take patients directly to the urgent care centre rather than through the Royal Stoke process. So there is work to be done, but there are things in train to try and support that.
Thank you, Paul. Chair, with your permission, I'll bring Jenny Collier in at this point to talk about the links with community services.
Thank you, Simon. So good morning, everybody. Yeah, I mean, Paul has touched on in detail, as has Mark, in terms of the work around the CRIS service. So supporting people to stay at home. We're also doing more work around the preventative pathway, so particularly around frailty and things like falls, so we can reduce the number of people being conveyed into hospital. And then, of course, we also have services as an alternative to ED, so things like the walk-in centre at Hayward and the minor injuries unit in terms of managing that activity away from the emergency department.
Thanks, Jenny. Chair?
Thank you. Let me bring in Colin.
Thank you, Chair. Thank you for your presentations. Just one question on ambulance times and waiting times. I know you've talked about this. I'll just give you one example. I was contacted by a lady from Ralston on Dove, and she was, I would say, quite an elderly lady. Her husband, who needs care, actually fell over in his bathroom. Now, she couldn't get, she physically could not lift this gentleman up. He's, again, got serious problems. And she was told by the ambulance, not the staff, obviously, but on the telephone, really, to say that could she pick him up and actually take him to the hospital. Now, clearly, she couldn't do that. Wasn't acceptable. But we have the problem. I don't know how we're going to solve this problem. 8 hours later, an ambulance did come, and he was rushed to hospital. But he could have died, and this isn't acceptable. I understand the problems, but how do we get around this? Because that sort of thing is, well, it's, as I say, it's not acceptable. And the gentleman could have died. He didn't, thank God.
I mean, I think just before ambulance colleagues respond, I think, look, I said at the start, and you've heard colleagues on the call say, where those situations arise, that's not what any of us want at all for any individual across Staffordshire and Stoke-on-Trent. So I think, part of this will be about what alternative do we have to the ambulance call that we can connect and link. So some of the community service offer, some of the offers from voluntary and community sectors, we've just got to make sure we just get into that space more and think really creatively. Some of this is developing. It's not where we'd want it to be yet as a suitable alternative, councillor. But your point is well made and well heard. And I think that's part of the conversation that I hope what you've heard from system colleagues today is, whilst we talk about numbers and percentages, actually each and every one of us comes back to the fact that it's an individual. It could be my mum, it could be my dad, it could be auntie, uncle, and we really bring this back to what does this mean in terms of the individual and the person, not just it's a percentage of this or it's a number of that. And I think, look, I offered that apology at the start in terms of where the service doesn't meet the expectations and the standards that we set ourselves. But I also recognise the really hard work that our frontline staff are trying to do to meet the challenges that we've got in this space at present. And we don't always get that right. Not acceptable, not justifiable. We've got to find some of those solutions, and we're working, and partners are working really hard on some of those solutions. Mark.
So I think the first thing I would say is just a wholehearted apology. None of us, least of all colleagues in the ambulance service, would ever want the type of response that we're currently delivering. Sadly, the example you've given won't just happen as an isolated issue at the moment. We'll have hundreds of patients every day that fit that exact same scenario. It really disturbs us, believe me, to hear those stories and to know that we've got patients as we speak who have waited over 9 hours and are still waiting for an ambulance response. I never ever thought in my whole career that I would be sat in front of a committee explaining why we've got such delays. The reality is that the system is completely overheated. We've heard every single bit of it is struggling to deliver the demands that are placed on it. In addition to that, we've got a workforce that are absolutely tired. They're on their knees. None of these people have been furloughed. None of these people have shirked responsibility and stayed away and seen patients over the phone. These people have been out on the front line dealing with patients face to face since the beginning of the pandemic, which for us was 2 years ago. So it was January 2020 when it all started for us. It wasn't March the 23rd like it did for everybody else, but our staff have been there with face masks, with aprons, with gloves, dealing with patients with COVID, sometimes stuck in the back of an ambulance with patients with COVID for many hours. So these are not staff that are shirking their responsibility. These are staff that are absolutely trying their best. But we've got a system that's broke. It's broken for not any individual organisation's reasons. We didn't go into COVID in a great way. We had handover delays long before COVID ever reared its head. What we've got, I think, is a perfect storm of factors that means that everybody now is really struggling. But what I would say, so our advice to patients in this category of call, so we used to say to patients, don't move the patient, don't let them eat and drink, because we'd get to everybody in under an hour. We're not doing that now. So the advice has to be different. And the advice to patients is eat, drink. If someone can move you to make you more comfortable, then they can do that. Because actually, 9 hours on the floor is going to cause harm. And for some patients, it will cause severe harm. The other thing is, sadly, some of our community responses, I remember communities where people would knock on the door, check their elderly relatives or check their neighbours. That seems to be disappearing. And to some extent, we've got to get some of that back. Because I can't believe there was nobody in Royston on Dove that couldn't have helped somehow those elderly people. Now, if we're doing our best and we're not getting to people quick enough, we've got to, as Simon says, use other services that have got capacity and also get the public to help us, because we've got to sort of mobilise all of those available resources, because we could put another 400 ambulances out every day, but we would still have similar problems because the issues we've got are so difficult to the handover delays is the biggest risk we've got, let's be clear. But even if we solve that, we've still got issues of demand. We've still got issues of staffing, making sure that, because our staff as well catch COVID and have to be isolated. So I think we've got a really, really complex sort of thing that we do need to collectively come together to resolve, because I don't think it can be resolved by any one organisation on its own.
Thanks, Mark. And Chair and Councillor colleagues, I think there's people have asked what can the councillors do and what can the public do. I think there's something about absolutely promoting NHS 111, supporting and promoting that community resilience and that community infrastructure in terms of working and looking after each other. It's absolutely about mobilising the voluntary and community sector to support and work alongside the services, and it's about that respect and understanding of the challenges that the NHS and local authority workforce are seeing day in and day out, and recognising that in terms of being respectful of that around how they behave and interact with colleagues.
Thank you. Colin, can I move on, or do you want?
Can I just say, I think the problem that we get quite clearly is people do panic, and the first thing people do, especially when that's in that situation, they ring 999, quite honestly. I think I take your point about volunteers in the area. I'm not aware of, in Ralston, of that issue. I just would like to thank, though, Burton Hospital, because that's where the gentleman went, and he was back home, so thank you for that.
Can I bring in Keith, please?
Thank you, Chair. I'd like to say, obviously we will support anything to do with the community activities. I know, I think Jenny knows this, Jenny Collier, that we've been working together on this. We've had some calls and things over the last year, and I know it's something that I hope we can put something together to try and help this idea of trying to have somewhere else to call. But the problem is, I think, is that there isn't, particularly out of GP practice hours. And I think this is when things really do pile up, potentially at weekends and in the evenings, late at nights and over holiday periods and things like that. I don't see anything within the plan at the moment to be able to alleviate that per se, but I would like to find out a little bit more about how many of the ambulance calls do you think are necessary? How many of them are if what you referred to as people that could, probably the wrong term with vaccinations around, but people who walk in to emergency and could turn up at A&E and things like that. What impact is happening that prevents the whole of the true emergencies being affected? And how can we try and reduce that demand of people who are turning up at A&E and at practice and calling ambulances that generally don't need to do that, or could in fact turn up themselves? And then also, finally, because I know it's the whole process that we're dealing with at the moment, is this, I like this idea of sedimentation, the fact that people can't move on within the whole hospital process back out to social services or social care, adult social care, and the fact that care homes at the moment do have capacity, but there still doesn't seem to be any way of moving them on if they need that. So they're the two elements of it. It seems to be a double-ended problem to which there doesn't seem to be any real solution at the moment, and I just wondered what people's comments are on those two areas. Thank you.
So really important point, and Mark, I've seen your hand up, so I will come to you, but I'm just going to bring a couple of other colleagues in as well. I think a really important point, Councillor. Look, I think that I just want to make sure we get a really important message over here, which is we are certainly not coming and having this conversation and at any point apportioning blame to the public in the slightest. I want to be really crystal clear in terms of that. If a member of the public thinks they need NHS services, then we need to support them to make the right decision and get them to the right place in a timely way. But this isn't about saying to individuals, just tolerate and put up with and don't come forward. This is really important message that we get this balance right. So this is not about blame. This is not about being inappropriate. That's not a language that we are looking to use at all as system partners across Staffordshire and Stoke-on-Trent. Where we've got to get to is how do we support and educate colleagues and local population to make good decisions, but then also make sure we've got the right support and the right facilities and the right services around in that regard. I'm going to bring in Dr. Fawcett to talk about NHS 111 and the kiosks that are available to help with some of that. And then I'll come back to ambulance colleagues.
Good afternoon, councillors. Yes, I'm Stephen Fawcett. I'm the medical director for the CCGs in the North. And I've been involved quite closely with the 111 programme for a number of years. I think coming back to the councillor's original point, which is about making sure that the ambulances are used for the patients that need the service, I think most clinicians would say over time that the usage of ambulances has become much more appropriate. I can remember being a casualty officer about 25 years ago when ambulances were transporting enormous numbers of ambulatory patients. That simply doesn't happen anymore. There are people who can walk off ambulances, absolutely, but the numbers have declined. I can't give you numbers, but they're certainly much less than I experienced when I was a nipper. I think Simon's point, though, about helping people to find the right service is absolutely key. As Mark alluded to in the earlier part of the presentation, as we all know, emergency services are difficult to navigate. There are lots of different portals, and nobody's quite sure what does the right thing or is the right thing for them. And that's where 111 comes in, because 111 is a service that is a gateway. It allows people to talk to a call handler, if necessary, a clinician, to talk through their issue and get guided to the right place. Now, the right place may be the emergency department, and about 10% of cases, that's where they go. Another 11 or 12% will end up needing an ambulance. That's also the right thing to do. But the key bit is that people are talking to somebody who knows what the services are for a range of conditions, and where there's uncertainty, they can talk to a clinician who can refine that still further. So the key bit is about making sure that that people have access to 111, and 111's available not just on the phones, but for other folk who are sort of digitally enabled, you can access it online. There's even a 111 app. And also, we're now extending 111 services to the front door of the emergency department. So if you walk into the emergency department now, particularly at the Royal Stoke, at the County, at Haywood, at Queen's, you'll be able to access a terminal where you can interrogate with the terminal will ask you what your issues are, we'll work through it, and we'll tell you the right place to be. Now, in some cases that will be ED, but in a lot of other cases it might be self-care, it might be primary care, it might be a pharmacist. Now, people won't be sent away from the emergency department on the basis of that. They will still be able to access care within the unit as appropriate. But what it does do is it tells people, actually, you could have got this seen somewhere else, much closer to home and much quicker. Because let's be honest, waiting in ED is not a bundle of laughs. It takes a while to get through that system. So being able to be educated as you go in and be told, actually, you could have got this done elsewhere. Gradually, people start to understand. We found this with GP home visits, which used to be almost ubiquitous and now are done selectively for those that need it. We can change behaviours, but it takes time. And the other bit is the ongoing comms programme, and that's multifaceted. It's been going on for some time and is a continuous process. We're not going to change things overnight, for sure. We're not. But we've got the building blocks for people to be directed to the right place and to help people. And I think that's the message that we really want to get out.
Thanks, Steve.
Thank you. Keith, I wanted to bring in other people, if that's okay. Phil Hewitt.
Thank you, Chair. I won't waste your time. My question has been comprehensively answered. Thank you.
Great to anticipate. So that leads me on to Janice.
Thank you very much, and thank you to everybody who's given us some information there. I found that absolutely riveting, certainly very informative in terms of some of the questions that I had at the beginning. We know what's causing the delays. We've got some detailed systems about potential improvements. We're looking at how some of those are having the positive impact. And we've also looked at some of the numbers that are being applied to that. My next leading question was looking at when you anticipated to see the impact of those initiatives, not least to do with recruitment. But also, I think now, and in terms of what we're dealing with at this very point in time, I've heard mention the perfect storm. We are obviously dealing at the extremes of things. Do you think that, or are there any conversations at the moment about Nightingale hospitals trying to alleviate some of those pressures as well? Thank you.
Okay, so thank you, Councillor, and I'll bring colleagues in terms of community bed availability. But let me address your final point first in terms of Nightingale hospitals. As far as we are aware, from a Staffordshire and Stoke-on-Trent perspective, we are not involved in any conversations currently around Nightingale hospitals. In the first wave of COVID, when they were established, the travel time for Staffordshire and Stoke-on-Trent residents would have meant it was Birmingham or Manchester. And we took a local decision with our local hospitals and with local partners to look after residents locally and to keep people as close to home as possible whilst we could manage that demand. And I think that would always be our first approach. Is to make sure that we've got the right capacity in our local hospitals to meet that surge and to meet that demand, and we were able to navigate that and manage that through the first wave. Clearly, that depends on numbers and it depends on capacity and it depends on availability going forwards, but we're not in any conversations at present in terms of Nightingale hospitals. So in terms of the first bit that you talked about, I'm going to come to Acute Trust colleagues. Because you talked about recruitment and the impact of recruitment and workforce. So it impacts on all of our services, but I just thought I'd start with Acute Trust colleagues first, if that's okay. Paul?
Yeah, so I mean, I guess that the challenge nationally with recruitment is the number of nursing vacancies, and every trust is sort of fishing in the same pool really for nurses at the moment, and we're trying to have a bit more of a joined up approach to it, so we don't move staff around the system, particularly in Staffordshire, around making sure we don't attract people from one provider to another. From a UHM point of view, we've had a relatively good recruitment of doctors for our winter plan and supporting that. That doesn't mean it's in a great place. You've got lots of consultant vacancies. Again, not a county issue. It's a national issue. We are looking at all of the modern technologies. I learned a new word last week, geofencing, which is where you send targeted adverts to people's phones on Facebook or Instagram or whatever social media that you want. But effectively, the workforce before the pandemic was challenged. It's even more challenged now. Bank nurses, agency nurses, not necessarily wanting to work in acute hospitals, but wanting to work in vaccination centres or test and trace, because you can do that from home, of course, rather than coming into a hospital. But we will continue to provide robust recruitment campaigns for healthcare assistants, for nurses to come into our system. We agreed a number of business cases last week, about £20 million worth of investment into UH&M for acute medical nurses, anaesthetists, all of those things, to try and make sure we are ready for recovery when we come out of winter. We will need staff to do recovery. The challenge, of course, is we'll need extra staff to do recovery, because the staff we've got is just doing what we do at the moment. So that will be our biggest challenge. So I can't give you it will change on this date, because we just don't know, other than we will continue to push for recruitment. We will continue to push for, when we come out of winter, a robust recovery plan.
Thanks, Paul. Duncan, Simon, anything for you to add?
Sits in the position really. I think the immediate pressure though on our workforce is the sickness and the shielding and the competency. As you know, numbers increase, you know, we're going to be back into that space of people being off, people being sick at our most intense time.
Thank you.
Yeah, it's a very similar position in the south part of the county as well. So and of course we're also overlaying this with the fact that you've got a staff group here who are suffering from fatigue as well. So this has been ongoing now. We've worked on adrenaline, we've worked on goodwill, purely and simply to get us over. This is now starting to look like mainstream business in a lot of areas, and it is incredibly tiring trying to work this way whilst we're still trying to recruit. And of course, some of the other areas that are other roles that were described a little earlier by Paul there. It is difficult to recruit some of these people when you consider that the level of violence that was described. Particularly, I know we were talking primary care a little earlier, but the kind of roles we're talking about here, there are other organisations who are now paying more for potentially the same role that we're trying to be fishing in terms of healthcare assistance, and that's really, really tough now. So traditionally, this has been a really popular career for a number of people, but all of a sudden we're finding other organisations who are paying more, and therefore it's an alternative for a number of people to consider. So it is really difficult.
Thanks, Simon. And Jenny, from a community service perspective and our community provider, anything you want to add to that, Jenny?
I mean, it's a very, very similar position in terms of recruitment. I mean, the same in terms of recruiting registered nurses in. One of our other challenging areas is therapy, given the level of rehab needs we have, both the people coming out of hospital, but also people in the community where we've seen increased levels of deconditioning. And then on top of that, there is also those people with post-COVID syndrome that need a level of rehabilitation. So a draw on our workforce across the board. We've been actively recruiting all the way through the summer. I think the big piece we're doing together as a system is around the domiciliary care provision. So how we can recruit people new into care to support the activities across domiciliary care and the home care issues we've got that are impacting on all of our services.
Thanks, Jenny. Chair?
Janice, very briefly, please.
Yeah, very briefly. It also links into another part of the report, actually. And you mentioned about the staff that are already under an awful lot of pressure and clearly have been exposed to significant physical and mental demands. It mentions in the report about the support that's being put in place. Are we aware of the uptake of that? And is it sufficient?
So I've not got facts and figures, Councillor, so that was probably one that we'd come back to. So I know we've got a combination of system-wide offers as well as individual organisational offers. My understanding is the uptake's been good. Is it enough and is it sufficient? I think is always an interesting bit of how much more do we need to go and how many more people need it. My understanding is there is capacity there for those individuals reaching out and looking to access it. So I don't think we've reached that capacity. I just hope that people feel as though they're able to access it and use it. But I think there's been good uptake. The support's there, combination between system-wide and individual organisations. But I'm not sure if any of our providers wish to add or comment on that.
I mean, only from again, UHN, we've had a good uptake. We've put on wellbeing sessions. We've got group sessions that is actually run through Jan Summerfield and the staff psychology support. Our crit care team have very bespoke programs. Our ED team have very bespoke programs, given some of the challenges that they have been through. But it is one of the things I think that particularly for UHN, I'm not sure what other providers are like, the effects of going into critical care the first time round for theatre staff, for people who aren't used to that environment, has been significant. And again, special individualised programmes for those individuals following that.
And I'm sure Jenny and colleagues can talk about this in more detail, but we've had community hospitals and care homes where potentially you would have had one death a week, a couple of deaths a week, where the numbers seen across the board has been significantly more than that, and that absolutely and appropriately for people that care takes its toll on individuals' mental health and well-being. And so we've made that offer, and the system-wide offer, the Psychological Health and Wellbeing Hub, is a really broad brush, open to as many people as possible in terms of individuals being able to access that. Jenny.
Yeah, just to comment on that, Simon, and one of the things our staff report is that real increased acuity that we've got across the community, and I think they are finding that incredibly hard at the moment, that they know we have a backlog across all of our services, plus the demand that we're seeing coming through at the moment, and not feeling able necessarily to do everything that they would want to do in providing the best possible care for people. So I think that also has a really difficult impact on our staff and supporting that well-being, that at the minute, certainly the motivation and the enthusiasm they have for their job is waning because they don't feel they're able to deliver their best at the moment. I think that's what we've got across all of our services at present.
Really important point, Jenny. Thank you for that, Chair.
Thank you, Angela.
Thank you, Chairman. Well, first of all, can I say I was in a very unfortunate position a few weeks ago. I used the 111 service, and I've got to say I was quite impressed. But my question relates back to what a gentleman said in the last half hour, actually, and it was about the pressure on Royal Stoke and nowhere else to take them at night. Do I get the message from the ambulance service that county hospitals should be open in the evening to relieve that pressure? Thank you.
No, that certainly isn't the message that I'd want people to go away with. I mean, what we've heard from some colleagues is staffing is one of the big critical factors in all of this. So opening more sites doesn't ease the issue of staffing. I was simply stating a fact. I mean, it is urban areas surrounded by lots of rurality, Staffordshire, which poses a significant challenge when compared to areas that are purely urban. So please don't take any sort of message away of something that I didn't allude to or want to say.
Thank you, Mark.
Thank you, Richard Cox.
Thank you, Chairman. I really appreciate what you've been telling us over this period of time. I think it has to be acknowledged what you're saying, and just as an anecdotal, we had an accident in my village. The phone call that I was on was tremendous. They helped through, certainly for the first 20 minutes of the accident. We were very fortunate that we had an ambulance technician off duty that was able to assist a serious broken ankle and so forth. But I got no admiration for you, and the only comment I would probably say is that you recognise that things are broken, you're in this crisis. I just do look forward to obviously knowing how, going forward, how that will be fixed, knowing that you've actually gone through the worst, and hopefully it is the worst and it can't get any worse. Thank you.
Thank you, Councillor. And look, whilst we're saying we recognise we've got some things that aren't working as we want, I think we will also say the way that system partners are working together to maximise the capacity that we've got and maximise those alternatives that we've got. It's certainly not a just wait and see what happens and let's hope we can fix some things further down the line. People are working really hard now, but a really important message, and thank you for taking the time to say thank you and to share that admiration. And I would ask our provider colleagues to pass that back into your organisations and into your teams and share that, please, with colleagues working on the front line and working in support of the front line to continue to deliver the services that colleagues are doing. Chair.
Thank you. Can I just ask one final question this afternoon, which is I often hear the phrase winter surge beds. Is there such a thing, and do we have a magic wand somewhere, or does it fit into the employee discussion we've just had?
Jenny, I'm going to come to Jenny first, then I'll come back to you, Paul.
Yeah, so in terms of community capacity, we do have winter surge capacity. So we have opened additional beds at Cheadle Hospital in the short term over winter. That has allowed us to decant out an inpatient ward. So we have more surge capacity at Hayward Hospital through winter. We also went through a big procurement exercise in October for the D2A care home beds. So we now commission a number of rehab facilities as part of care homes up and down the county. But through that, we put a framework in place that's allowed us to put extra surge beds in those care homes. So at the minute, we have 27 block book beds throughout the whole of winter, and we're going into additional spot purchase beds on a specific patient by patient basis where there's a certain need that we can't meet from within those surge beds. So we do have surge capacity. Similar for Home First, we have surge capacity in Home First, but the challenge at the moment we have is that a lot of that capacity is being used for home care provision, where we've been unable to discharge people because of the lack of domiciliary care in the community, which is again what we're working together on as a system in terms of the workforce challenges there.
Thanks, Jenny. Paul?
Yeah, at Royal Stoke we have 3 wards that we call winter wards. 2 of those are open at the moment. One is the vaccination hub and is planned to open at the end of the month, and we have 1 ward at County which opens today.
Duncan, Simon?
Yeah, we're in a similar position actually. So we've already got some of our pressure wards, is what we're calling them now, because it's no longer winter. They can open at any point in time. So some of our pressure capacity is already open, exactly the same as what Paul's just described.
Yeah.
Similar position for ourselves, Simon, across the board, and we're hoping to open beds, which will be just straight after Christmas at the community hospitals. So a few more beds to help with the pressure.
Thank you, colleagues. Chair?
Thank you. I'm not seeing anyone else indicate from this side, so if I could just summarise where I think we've got the conversation to. I think whilst there was the example of the CRIS service and the benefits that's having within the ambulance service, it sounded to me like there was an opportunity to broaden that and roll that out further. It sounded to me like there are opportunities still in terms of looking at a different landscape. But at the same stage, it sounded to me like there was a system-wide action plan that is sitting behind some of today's conversation. And it would be useful maybe to see the system-wide action plan just as a follow-up out of today's discussion. But otherwise, in terms of summary, first of all, recognise the issues that everyone within the system is facing. I think they were very clearly enunciated by a variety of partners who, in my view, showed no side apart from wanting to solve the problems and not necessarily to lay blame at any one individual organisation's door. So really useful. Thank you for that. Thank you for today's presentation and the rallying cry to work together to benefit all of our residents within Staffordshire. I'm going to call a halt to that agenda item. You're all welcome to stay or go, depending on how you feel, but thank you for everything you're doing. Committee appreciates that.
Thank you, Chair.
So item number 5, home care. Now, I think Richard might well lead on this, unless Julia's going to nod. I think... Julie, would you like to say a few words just as introduction?
I'll just do a very brief introduction, because I think a lot of the issues have been discussed in the last 2 agenda items as, with regards to pressure of services and recruitment and retention of staff. Since COVID started and restrictions have eased, there's been a significant increase in the demand for home care services. The absolute reasons for this are not known, whether there is a reluctance for people to go into care homes and prefer home care as an alternative, or whether it's the fact that people have been subjected to restrictions that have affected their mobility, their other physical and mental health as well. But the increase has been in the region of about 20%, which I think is reflects the situation nationally. There is a backlog of assessments, and I won't go into the detail because the report sets it out quite clearly, which isn't good for those individuals concerned and their families. It does have an impact on discharge from hospitals and the Home First service and beyond. So this is a report that details out how we're working and trying different initiatives to reduce that backlog for care assessments, safely managing demand, because that is of paramount importance, maximising the available capacity, incentivising the uptake of packages of care, particularly more complex packages, the recruitment and retention initiatives, and creating extra service capacity. There is more strategic work being undertaken with regards to recruitment and retention, because this report identifies things we're doing now to try and address the difficult circumstances at the moment, but we recognise that work needs to be done to address this in the medium and longer term. Thank you, Chairman. I'll hand over to Richard.
Thank you, Chair. I won't say too much more by way of introduction. Just to stress that the twin pressures of rising demand and challenges with the workforce are national problems rather than local problems. Every local authority, every health and care system across the country is facing exactly the same issues. Councillor Jessler has given the reasons for the increase in demand, and as she says, it looks to be up by about 20% since July, which is pretty significant. In terms of supply, the workforce challenges are really starting to bite some of the providers. It is getting more and more difficult to recruit and retain staff. We are trying to be as proactive as we can in how we respond to that. So the mitigations to the backlog of Care Act assessments are set out in paragraph 7, and the mitigations to try and increase home care supply are set out in paragraph 8 under those 5 headings of managing demand, making best use of the capacity we've got, incentivising take-up of packages, supporting recruitment and retention, and then trying to create additional service capacity. I think it is worth highlighting that we are working very closely with NHS colleagues on these issues. We're very grateful to the local NHS for 2.8 million, which we are now distributing to home care providers to try and fund loyalty schemes to retain staff over the winter. There is an additional national pot of 162 million, of which our share is 2.5, which we are also getting out to care providers, again to provide incentive and loyalty payments to staff. And I understand that further funding is likely to follow from the Department of Health and Social Care. These are very tricky challenges. They are a long time in the making, but they are making themselves known very quickly now. Again, we will continue to do all that we can to try and address them, and we will be monitoring the position very closely over the next weeks and months. Thank you.
Thank you, Julia. Thank you, Richard. Charlotte Atkins.
Thank you, Chair. Just a few points. In paragraph 10, there's talking about development of career pathways. Isn't that incredibly difficult given the funding issues and the fact that we often can't recognise the ability of those staff by rewarding them sufficiently for the work, the very difficult work they do. So that's the first point. Second point, I'd just like to know how many, it's on page 113, how many packages of care are handed back? I mean, is that a significant issue? Number two. And number three, on page 114, there's talk there about flexible call times. Now, I appreciate that that might work for some, but I'm sure that there are plenty of people who are supported by this service who perhaps either are working or are volunteering. Not everyone that is being supported by this service will be confined to their home. And so therefore, I'm concerned that when you talk about flexible call times, that this is recognised that not everyone is in a situation where they can wait at home for that help in terms of getting them up, washing, dressing, and indeed at the end of the day, getting to bed as well, which I think is important because, you know, people have a life and, you know, being put to bed at 7 o'clock at night is not really appropriate. So I just really like some of those issues addressed. Thank you.
Richard, are you starting, or Julie, would you like to start?
Happy to go, Chair,
Yeah.
unless Julia would like to say anything.
No, if you carry on, Richard, thank you.
Okay, so first of all, on the career pathways. So the mitigations set out in paragraph 8 are largely short-term. We are acutely aware that we need to twin track that with some more longer-term and strategic work. The career pathway is trying to encourage people into the care sector whilst recognising that our ability to dramatically increase pay and make terms and conditions of better is probably constrained. What it might look like is a career offer for people such that they might join a care provider as a home care worker for a couple of years. During that period, as well as working on the front line, they might be offered some courses to develop their skills and abilities. They might then transfer into an NHS provider for a period of time and develop further their knowledge and skills. Again, we might be able to offer further training during that period. Rather than being a short-term job that people take on, they would be offered a sort of 5-year career plan going from care providers into the NHS, maybe back out again, with the hope that that might be rather more attractive and encourage people into the sector. So these are early days yet, but this is some of the thinking with NHS colleagues. Second question was about handbacks. So in the usual scheme of things, numbers are low, and they typically happen in circumstances where there has been perhaps a falling out between the provider and the client, such that the provider no longer feels able to meet the needs of that particular client, and they then have to hand it back and we have to find somebody else. We do try and keep those to a minimum. There are some circumstances where it is absolutely unavoidable, but on the whole, we do encourage resolution of those issues. It can happen to a greater extent sometimes if home care providers fail. So the biggest one in the last few years was Allied Healthcare, when we had to transfer about 300 packages almost overnight, and we transferred those to Nexus. We do fairly regularly get providers fail, unfortunately, and they then hand back their packages, and we have to transfer them to other providers. Again, on the whole, we've managed to accommodate those events pretty effectively, but it does create a lot of additional work and a degree of distress for those clients and their families. Last question was about flexible call times. This is the scenario whereby if call times are very prescriptive, they can be quite difficult to resource. So if a care and support plan says that a call must be at precisely 8:45 in the morning, 12:30 noon and 5:45 p.m., it rather constrains the ability of providers to be able to meet that. Whereas if they are more flexible and they say morning, noon and evening, it just gives providers a bit more flexibility about how they use their staff. Obviously do recognise the point that we do have to accommodate people's preference and choices and try and fit it in with their lives. But we are trying to balance doing the right thing for each individual with being able to use those resources most effectively across a large number, several thousand of individuals. So it's just trying to give us the best balance between those two imperatives. Thank you.
I just want to come back on the 5-year career plan. How close do you think we are at trying to attempt to do that? Because clearly we have very short-term pressures on staffing, and I can't see that we're near enough getting that career plan to encourage people to join the workforce.
Yes, thank you. I think we are some way off being able to make that the norm. I think we are perhaps rather closer, by which I mean perhaps 6 to 9 months away of being able to pilot something on the scale of perhaps a few hundred staff members. I think that this is a relatively evidence-free space, and I think what we would want to try and do is have a go at a few things, offer some different career pathways and options, give people the chance to try them, and then learn from that and then develop something rather more large scale over time. Thank you.
Julia Jessel.
Yes, I'll just add on to that. I think there's 2 points I'd like to make. Is working closely and jointly with the NHS. In many respects, both the NHS and adult social care are in the same business of looking after vulnerable people. And I think it is extremely important that we work together with them and potentially develop joint care career paths rather than fighting each other. If we're not careful, we'll be poaching each other's staff, which is not helpful for the people that we look after, nor either of our organisations. And I think the recognition of that close working has been that funding that the NHS locally have given us, and I hope that constructive working arrangement does continue. I think in terms of Charlotte's question, it's a very valid one. We are in some respects currently firefighting, but both Richard and myself are very strongly of the view we have to start planning for the future. You can't make progress actually with just firefighting, and actually developing these career paths, trying different approaches. And I think what we have to accept is that not all of these initiatives will work, but my goodness, we'll have tried pretty well everything. And I think that is what we need to be seen to be doing, working and supporting the various providers, but actually trying different things. Some will be more successful than others, but I think the failure would be not to have tried at all. And I think what we're doing is constructive. I think it's being seen as being constructive, and at the end of the day, our focus is on providing the best service we can to the people who depend on us within the resources that we have available. As I said at full council, I'm keeping my fingers crossed that actually we do get a 3-year settlement from central government, because that actually does help the planning. Thank you.
Keith.
Thank you, Chair. I noticed that maximising effective capacity is one of the items in the report. And I just wondered how that differs from the idea of creating additional service capacity, which is under E. Obviously, I should maybe declare an interest, being one of the councillors that works within the North Staffs area, and just wondered what difference there is between those two, and what sort of, is there any exciting news you can tell us at the moment, or are you still working on how those two elements of creating extra service capacity as a pilot is going at the moment? Thank you.
Richard.
Yes, so making best use of existing capacity includes what we talked about earlier about flexible call times. So that means there are about 46,000 hours of home care being commissioned, and it's about making sure that all of those are being used to best effect. The new capacity is about actually trying to recruit some more staff and create additional hours. The first stage of that is to create an additional service in the north of Staffordshire and Stoke-on-Trent, and it will be provided in the first instance by Stoke-on-Trent City Council, but outreaching into Staffordshire, and that is attempting to recruit some additional staff to create some additional capacity, which would then alleviate some of the pressures and backlogs on the Home First service and allow them to take more people out of hospital.
Do you want to come back?
Yeah, I just wondered if there's any sort of time scale on that. You've given some ideas about when that might be occurring. I realise that obviously recruitment's a big issue at the moment, but just wondered what you are expecting at this stage, time scale.
So the critical constraint is the supply of staff. I believe Stoke-on-Trent are actively trying to recruit to that service at the moment. I don't have the figures for how many staff they've actually got, but I think the endeavour is to try and get as many people as possible into that as quickly as possible, with the caveat that what we don't want to do is just re-employ existing home care workers. So it doesn't help us if a new service just re-employs the staff that are already employed by other providers. You don't get additional capacity then. All you get is recycling the current people. So that is another thing that Stoke-on-Trent Council colleagues will have to think very carefully about. This is about genuinely new people into the home care sector.
Thank you, Richard. Janice.
Thank you very much. Just going on from that part, I think it's worthwhile maybe having a little bit more information about how some providers are commissioned at a higher rate, so can provide an enhanced remuneration package, and then that facilitating some of the moving around between different providers. And as an additional question as well, a separate one, some of the initiatives that you mentioned are looking at changing potentially some of the safeguarding aspects. So, for example, using non-contracted providers. And it's just a quick question as to how we can ensure that the safety of the users of those services are going to be maintained. Thank you.
Richard.
Thank you. Yes, so the council has two standard rates for home care. One is the standard for most of the county, and the other one is an enhancement for the most rural areas. And that just is to reflect the additional travel times and the costs that accrue from that. At the moment, about 93% of all of our home care is commissioned on those two rates, which is actually very good. We do have to use some non-contracted provision where we're unable to secure a contracted provider. The risk of that is, as was outlined, that our quality assurance is less well developed with non-contracted providers. We mitigate that by just trying to keep in touch with those providers and those individuals so that we do make sure we've got sort of eyes on them. Where we sometimes run into difficulties is with the difference that the NHS pays the home care providers and the two local authorities, and sometimes that can create a bit of internal circulation of staff. And I believe there are efforts to try and harmonise that as much as possible to try and avoid perverse incentives for staff just to move from one service to the other. Because again, it isn't helpful to us if people are just moving around the sector. What we need is new people actually coming in.
And the point on safeguarding?
Yes, sorry, Chair, I did try to cover that. So this is the small number of people who are looked after by non-contracted providers. Again, it's about a figure of about 7% currently. Again, the way we try and mitigate the risk of underdeveloped quality assurance is by regular conversations with those providers. Any concerns are obviously dealt with within the usual safeguarding channels. It is not a risk that habitually crystallises. In other words, we have no particular reason to believe that those providers offer a less good service. It's just that our normal QA processes don't apply because we're operating outside contract.
Thank you, Richard. Philip Hankins.
Thanks, Chairman. Yeah, this is always a difficult one. I'm just going to talk about the recruitment and training. Obviously, you're trying to get upstream of everything, and I can understand everything that's going on. But to make a career in care, there are an awful lot of people who would like to, I think they'd probably like to do it. It's a job that gets some satisfaction when you're actually working with people. And mine's, on the point in the paper, it says training offers and grants to support staff into MVQs and help develop a career pathways. I'm a college governor in South Staffordshire, so that covers 4 sides. and I've got a bit of knowledge of it. And the further education offer has changed quite considerably just of late because of the way the government regards skills training now. So my question's around who's taking the lead on this? Is it the county council? Is it the colleges? Is it the providers of the care homes? Because I think what you'll find is it's a very fractured and fragmented background there that we could take a lead in offering a career pathway for those who want to take a career in care and point them in the right direction of the necessary training modules and MVQ levels and everything else so that you end up with the workforce of the future, not, as I'm listening, the workforce of the past who are being chased by different organisations as to whether they are, you know, can you come and work for us or can you work for them? So it's more about the future. And I'm telling you, FE's changing. It's no longer 6 to 19. There's loans available for people over 25. So if you want to train and your children have grown up and left home and you're in your 40s, there's grants and training there for people of any age to get themselves trained into a care job.
Yes, thank you, Chair. So I think it is the County Council that will have to lead on this initiative. We have produced an outline project plan, which Cabinet looked at informally just last week, actually. In saying that we will need to coordinate it, we will, of course, need to harness the input of all sorts of other agencies, so the NHS in particular, but also, as quite rightly been highlighted, the role of further education colleges, care providers themselves. And I think we will need to do quite a lot of evidence gathering as well to try and ask people, what is it that would attract you to a career in the care sector? So that would be part of the project plan to try and underpin this initiative with some real evidence about what it is actually that would attract people to come and work in home care. Thank you.
Julia Jessel.
Yes, just to reinforce the answer that Richard's given, that following a draft paper that we discussed at Cabinet last week, I should be working closely with my colleague, Councillor Philip White, as Cabinet Member for Skills and Economy, because I think this will be a joint piece of work. It's not just about social care. It is about the issues that you've raised, Councillor Atkins, about further education and how we can create a career pathway that attracts people into this caring profession. As I said at full council meeting, I think it's really important that we raise the profile and the status of this caring profession. The status of NHS workers, you know, we've all clapped them and praised them, quite rightly so, but I think the other care sector has actually been neglected, and this, I think, is part of raising that profile, raising the attractiveness of it as a profession, as indeed it is. Thank you.
Philip, did you want to come?
Yeah, I think as a career pathway, it certainly needs a slightly different emphasis from the ones that people do use into the caring aspect. And also, particularly with home care, there's an opportunity to move it around your life as well. So there may be some who want to do a bit of part-time home care, you know, and fit around their lifestyle and all the rest of it, and take care of a job that may be locally available, but also make it professional because there's qualifications and everything else that go with it. I can remember my time at Burton where there was a story of a lady who'd family grown up age 40, was working as a volunteer, I think as a dinner lady at a school, and then went on to get a job in a care home as the cook. The care home manager suggested that she was a good carer and she did some social care training, and over a period of time, I think about 3 or 4 years, she ended up with a bit of support as a registered state nurse. So, you know, there's opportunities there for people that they've never ever thought of. And, you know, Job Centre Plus are not the best careers advice service. It may be that you need some examples like that lady I've just spoken about, who must have retired by now, and use those as examples, because people will look at that and think, that's what I want to do.
Thank you. I don't think there was a question in there, so but I think it's a useful example. I would just make one other point, and I think sort of Philip touched on it clearly in his role as Governor of South Staffs College. There are other councillors, particularly in this chamber, who are governors elsewhere, and I would encourage you to use the skills that you have within the council, and even maybe outside of the council, in terms of who can push this agenda with those further education colleges, universities, and both further and higher education. I'm not seeing any other indications, so I think it was a useful session. Thank you, Julia. Thank you, Richard. Clearly, all of these are interlinked, and I think all of the discussion today over the last 3 hours has linkages backwards and forwards, and clearly it's really important that the knock-on effects of the backlogs within the systems are eased as much as possible, particularly as we go into winter pressure. Thank you. I think that probably covers item 5. Item 6 is the exclusion of the general public. I have nothing to need to exclude the general public for. So what I'd like to do is thank you for your attendance today, everyone. Wish you a safe journey home, and more importantly, wish you and your families a memorable Christmas and peaceful New Year. If you want to take any of the biscuits or mince pies with you as you go to sustain yourselves, please do. Just joking aside, please do take some time to care for yourselves over the next few weeks, just to make sure that you come back fully refreshed, because frankly, I think today indicates how much work there is for all of us to do as we come through the next part of the pandemic. So please take some time to celebrate with friends and family, but do also come back raring to go, because boy, have we got some work to do. Can I also thank our guests today for their attendance. To have such a senior level of attendance, I think, is particularly important. But thank you all. Have a good Christmas, and we'll see you in the new year. Thank you.